Welcome, welcome. Welcome. Thank you for joining us.
Thank you. Thank you.
I will make a short announcement of each of us for the people who are watching us via YouTube. So we are ready to start officially. Now it's exactly 10 o'clock, and I would to welcome all of you for the annual meeting of Serbian Neurosurgical Society, this time virtual meeting with international participation. This is the second day. Yesterday we had the first day of our annual meeting. Session was on Serbian for the Serbian Neurosurgical Centers, and participants for Serbian language. Now we have this international day, and I would like to thank all of distinguished colleagues and neurosurgeons, friends from all over the world who join us for this official meeting, and who are now willing to share their experience in fighting with this situation which was caused by pandemic COVID-19, which is a real problem for the real life and the organization of neurosurgical practice all over the world, as we know. Your experience will be of outstanding importance and extremely precious for neurosurgeons in Serbia and the region. We have distinguished representatives of all continental societies. We have highest officers of the World Federation of Neurosurgical Societies here with us, and European Association. We have also representatives of Southeast European Neurosurgical Society. So we are ready to start. In order to be effective, I will now just officially start the meeting by inviting President of World Federation of Neurosurgical Society, Professor Franco Servadei, to give us a lecture, COVID-19 virus and our lives, including neurosurgery, which I believe will be with highest impact for all of our colleagues. Professor Servadei, please, can you start?
Yeah, Lukas, dear. Okay, can you hear me now? Yes. We have been first of all, I thank Lukas for the organization and the Serbian Society for giving us the opportunity to exchange our experience. The World Federation is very close to all neurosurgeons who are involved in the fight against the coronavirus. Our life and our experience and our way of working has changed tremendously in this period. So I will share with you our experience. Yeah. Can you see my screen? Okay, thank you. So this is the situation as 26 November in the world. We have over 60 million people infected, with the large population of Europe, which is here infected, and some part of the world like Americas and Southeast Asia also involved. These are the countries with the more numbers of infections, and you see the first one is United States, then we have India, Brazil, Russia, and then most of the European countries, including my countries. And if we look at the number of deaths per million population, unfortunately, my country and Spain are very high up together with United Kingdom. So we have a cluster in Europe of countries very deeply affected by the coronavirus. If we look at the publication, the the topic COVID has been the most published topic in the history of the publication for medicine. We had almost 70,000 publications in 8 months, which means a large number of publications. And if you look for COVID, it will be the same for COVID and neurosurgery. The picture of publication is different from the usual one. Usually, whenever we publish in medicine, the United States are over 30–35% of publication, mostly over. Here, they are the second after China and close to my country and other countries. We have a phenomenon which is called putting the pen down during the pandemic. There is a paper published by the Journal of Neurosurgery telling us the tremendous increase of papers sent for publication, you see it here, this year as compared to the year before. And this is the same for every neurosurgical journal. We have a lot of papers sent for publication. Most of them are dealing with COVID and neurosurgery. You see it here. Again, this is the distribution of the most publishing countries. You see it here, which is different, as I told you, from the one we have usually. Usually, United States are around 50%. In this pandemic, it seems that the scientific leadership of the United States is under discussion, at least concerning the number of published papers. How did we keep neurosurgery working in these extreme conditions? There are 4 important surveys, most of them done by authors who are here today. There is an American survey, which is the impact of COVID on neurosurgeon, which is a global neurosurgical study coordinated by some author from United States. There is a European study, it's here. There is a study, very interesting study conducted by Professor Al Gandour in Africa and by many other low middle income countries. And there is the last European study, which was published in the ACTA very recently, containing almost all the European countries. These studies are telling the same. When the pandemic arrived, most of the hospitals were not prepared, and they almost half of them were not prepared to face the pandemic. The same thing happened all over the world. The number of elective surgeries was canceled is around 50%, but if we look at the number of surgery which were canceled by more than 75%, we reach up 70–75%. So around all over the world, around 70–75% of non-emergency surgeries in neurosurgery were canceled. The surgical indication changed. This is an European survey showing that a similar case before pandemic would have been operated within 14 days. During the pandemic, either will not be operated or later. So the situation changed deeply. And another important issue, if you look here, there is a deep decrease or cancellation of scientific and research activities for our trainees. Then we have to consider that many of our young neurosurgeons have been shifted to pneumology to help the cure of the disease, of the COVID disease. This is a paper from our colleagues in Bergamo, which has been the most hit European province of all over the Europe, and that they have been shifted to cure COVID patients and reconverted to pneumologists. But the same happened in the United States. You see that here it's a guide for pulmonary care for neurosurgeons. So there is, and then we have to face how to keep neurosurgical alive in this difficult situation. This is what we are doing even now, we are working on a region based. My region has 10 million inhabitants, and every week we meet on the web and discuss how to deal the cases, how to shift the cases, how to shift neurosurgeons, how to fight in this difficult situation. And this is a good sign that we can work all together. Then we have changes all over the world in education. This, you see that almost 90% of residents in United States and in Canada had a restriction of their responsibilities. They, almost all of them, reconverted the frontal lessons to electronic platform. 75% were the word rounds were transformed into an electronical base. In my country, the University of Messina coordinated a national-based program where all the residents of Italy were reconverted into an education on the web, a centralized education for all training schools, which has been something which we never did it before. You see that this is one example. And we had up to 485 training neurosurgeons of the country to participate to webinars. And the same happened in India. You see it here, there is a platform which has been transformed into a center for education. Similarly, we had a transfer of experience in Indonesia, Malaysia, Thailand, and other countries, Singapore and Philippines. But the most interesting findings came from Africa, where they told us that these efforts of webinar education is important for them, because before, most of them could not travel to meetings, could not have the same high-level education that we are providing now. So we found a light in this dark period. The light is that webinars are accessible from all over the world, even for young neurosurgeons who could not do it. And this is true. This is a survey done by the Global Committee of the World Federation. The survey, as you see it here, was mostly done in Africa and Southeast Asia, so low middle income countries. And what they are asking is continue the education virtually. Don't stop it. Please don't stop it. So you see that the World Federation, as I'm going to the end of my presentation, the World Federation was the first worldwide organization to stop meetings at the beginning of March and oblige all our societies to work on the web. Working on the web for us was something important, but we were not unused to it. We have to support our educational activities with webinar already before. You know, this is a webinar of the young neurosurgeon group done in 2018 out of the COVID period, where we had 1,300 contacts on YouTube. So you see that the possibility to have education and teaching on the web was already there. This is the committee for spine, the spine committee of the World Federation. They had a series of 14 webinars before the pandemic, all of them on the web. So there was already education on the web, and this is what is happening now. I could not count the meetings that were done by our committees and by the World Federation, and with the logo of the World Federation, it is from March, it is more than 300. So we have a lot of the meeting. If we do education in the web, what do we miss? Obviously, we miss the cadaver labs. It's not anymore possible. Obviously, we miss that our work is manual work. So we need repetition, access to experience, cadaver labs, and surgery. And this is something that the web cannot give us, except the few experience on simulation. This is the paper that our group, we published concerning digital teaching, and you see it here that we do have possibility to have on the phone or on an iPad a virtual neurosurgical field and approaches. So there is the possibility to do it, to work on this. And we also have a project called Upsurgeon, who has been supported by the European community and by many other society, which is converting cadaver and surgical approaches into virtual approaches on the phone. So the future, we think, will never be like the past. And in this difficult situation, we found that we have invented something. So as the Latins say, mater artium necessitas, the necessity is the mother of the invention. So we are in a necessity. And we have learned also from another Latin sentence that not all the worst is coming for doing worse. Sometimes it's coming for doing better. So as I told you, the web education is free. This is what I received for questions in a recent seminar. Uganda, Libya, Yemen, Democratic Republic of Congo, Uganda again. So these people, could never attend any meeting in person. They are now with us. So this web education, in my opinion, as president of the World Federation, and I think my opinion is shared by anyone, is here to stay. We have to combine in the future in-person meeting and online education, because we have seen that we can reach all the world. And then our residents have learned how to prioritize our surgery, keep emergency surgery alive, and how to work together from remote distances. This is my final slides. The next Friday, in 1 week, the COVID-19 and neurosurgery issue of focus will be available. I was the editor of this issue together with Miguel Arrao, Professor Chen from from China, Professor Golfinos from United States, and Professor Qureshi from Kenya. And there will be an entire issue of neurosurgical focus dedicated to COVID and neurosurgery. Thank you for your attention.
Thank you, Professor Sevadei, for your outstanding presentation overview of this global situation. And we have a time for some discussion between the panelists. And of course, the discussion is open through the chat. So if somebody wants to make a comment or ask a question or something, please, we have some time. So I'm not seeing anybody that is raising the hand or would like to comment. Professor Sami, please turn on your microphone, please.
I would like to thank Franco for giving such an outstanding presentation with information almost about all over the world. And particularly my thanks belong to his opinion about the future, and we will probably reach much more people with webinar and with this restriction which we have for the meeting, as the other people cannot participate in international meeting. And I can remember, perhaps every of you can remember, in 2017, during my anniversary in Hanover, which we had, of course, about almost 700 colleagues participating, but that for the first time, we decided to open this meeting to all the world, and we had 10,000 participants beside our 700 who have been in Hanover, so that they appreciated. And the advantage was even we had 3 parallel sessions, but they was registered and they could follow even all the 3 when they wanted to go back to one topic they were interested in. And therefore, I am sure, Franco, in future we are going to have more communication system for education of particularly those people who were not able to travel around the world and listening to the new discoveries in neurosurgery. Thank you very much for your suggestions.
Thank you, Professor Sami, for your valuable comments. Is there anybody else who would like to make a comment or a question? So far, there is no any question or comments on chat, so we can move on. I would like to invite, it is my great pleasure to invite Professor Majid Sami, our great friend, mentor, and supporter, president or honorary president of the World Federation of Neurosurgical Society, and president of International Neuroscience Institute in Hanover, and many more. Please, Professor Sami,
So
tell us about the impact of COVID-19 on neurosurgery in Germany.
If I can.
Just share your screen. Yes, just share your screen on the
Yeah.
panel.
Yes, just a moment. Can you see the
presentation down on your control panel on Zoom? You have a share screen. Just share screen, and then your desktop will appear.
Here I am. I have here my presentation. Now can you connect it?
Doctor, you are connected. Just move your mouse so there will appear a link to share
Is
screen.
it connected?
You are connected. We are hearing you, but we are not seeing your presentation.
Yes, here.
So please move your mouse.
Yes, here.
Green link share screen will appear, and then from the offered choices, you will choose your presentation to share with us.
Yes, I am trying now.
Just move the mouse, and beneath your picture there would be a green link share screen.
Yes, I am trying that, but here in here. Can you see my presentation? Yes? Hello?
No, not yet.
Not yet. No, because I am.
Ajmo ti iz početka.
I can.
Professor, just move your mouse. Just move anything on the screen.
Yes.
There is a green link in the
Yes,
middle of
on the screen, I am trying to get the presentation of the things, but it doesn't.
Yeah, okay.
come.
Just click on share screen. It will give you few options of the files you can share, and then you'll choose your presentation.
Okay, here. I have my presentation, and here is, but you don't see that, no?
No.
Oh.
Don't click on presentation. Click on Zoom meeting. There is a Zoom meeting going. I mean, there is a screen with you talking to me. That's the Zoom screen. Just move your mouse on the bottom of the Zoom screen. You will get a green link. Share presentation. Do not go to your presentation. Rather go to a Zoom
Yes.
panel.
But that is exactly, it is written here down.
This screen pops up when you go over our photos. It will pop up, and the green is share screen.
Yes, I am trying this all the time.
You see share screen.
It is
Green
the green,
one.
green, yeah. Microsoft.
This is pop up.
Yeah, you see under your picture is
Yeah.
green, note. Yeah, when I push that, but it doesn't connect it. You know, I don't know why. All the time when I was.
Maybe sometimes I think you have to log out and come back again, and then it might start to work again. That's the other option.
It's not. You see, when I push, then this green.
You can, Professor Sami, you can just see on the Roman Bosniak screen. There is a share screen. Then when you click the share screen, your desktop is appearing, and then you start.
Yes. Desktop 1.
Yes, desktop 1. So click on that. Click on that, and then you will find your presentation.
Then system, Zoom, Bildschirm erlauben. Yes, I have done it here. Then I say okay, and now I can you see me?
Yeah, we are seeing you all the time and hearing you very well. And
no, I mean you cannot see you cannot see my presentation. This is the problem.
Not yet. Take your
Lukas, can the support take care of his computer remotely? They can remotely control the computer.
We can support this computer remotely, of course. But Professor Sami, can we do it remotely from here?
I beg your pardon?
Can we do this remotely from here, and then Professor Basant Misra can start his presentation, and then we will speak after him, okay?
Okay. But I don't know why I am all the time trying to.
Okay, now you will receive a call from our administrators just for the coordination, and I kindly to ask Professor Basant Misra.
There is something wrong.
No. First Vice President of World Federation of Neurosurgical Society from India to give us his lecture about neurosurgery in India during the COVID pandemic.
You can see my screen?
Yes.
Okay. Thank you, Lukas, for this great organization. It's a pleasure and privilege to be here. And I will share you some of our experience in India during the COVID time. It's a very nice overview by Franco, and almost all of us have the same experience we have shared. And this is based mainly I did an editorial which has come out last month, and on the neurosurgery, ANS neurosurgeon, I had written something a couple of months back, and this based on that. So COVID-19, the first case in India was on January 30, 2020. And till yesterday, the count is 9,393,000 odd positive COVID cases, of which 450,000 about who are still active. And we have lost 136,733 to COVID in India as of now. So you can see our case fatality ratio rates are a little lower than what we have found in Europe and in North America. And there are many hypotheses, probably because of a milder disease, maybe a different strain, or maybe Indians have immunity because having had multiple infection as a child, or because being exposed to a lot of pollution, probably we are stronger. Our body is stronger to virus than Europeans and North Americans who have a better environment to live in. So this is the graph of COVID-19 in India. You can see we had a peak sometime in September, then it came down. In fact, it came down to quite decent levels about 3-4 weeks back. And we have this festival season, which is started about a couple of weeks back and is going on till end of this year. And so then again, there is a spurt. And in some parts of India, it's still very bad. Delhi is very bad still. And there is still a lot of restrictions. But most other parts of India is almost everything is open. Except the schools are in most states are still closed. The international travel restrictions are still on. Domestic travel is limited, but the economy has actually, surprisingly, has rebounded very strongly. So the government response to COVID-19, we had a very early lockdown, and all health professionals below 55 years of age, including neurosurgeons, were on COVID duty, including in my hospital. All elective surgical procedures were suspended initially in March and April, and extensive testing only happened a later part of the pandemic. Initially, the facilities were very limited, and there were strong regulation by the government not to do it because of the availability of the testing facility, especially the PCR. But now it is extensive. There is no restriction. Anybody can go and get it tested. Previously, you had to have a prescription. You have to be symptomatic to get tested, and so on. So currently, as I said, mostly it's open most parts of the country except schools, and international travel restrictions are still on. We had a very high infection rate. I think the numbers what we have quoting here are much less than what number of people who have been infected in India, because the detection rate are probably much lower than most parts of Europe and North America. But we do have a low case fatality rate. There is no question about it. And surprisingly, the very strong recovery of economy in the last month or so, and last week, the stock market reached the all-time high ever, for whatever reason, nobody understands. The healthcare, we had different facilities were opened up in India for mild symptoms, moderate symptoms, and severe symptoms. For mild symptom, public halls, schools, the ground facilities were converted into COVID facilities, hotels, lodges, railway carriages were converted, and moderate symptoms were observed in peripheral hospital wards, and severe symptoms were admitted to designated hospital with intensive care facilities. And these are some of the for mild cases. This is a jumbo facility in a playground, which was converted to COVID care facility. And that's a rail carriage. Compartments were converted for isolation of patients. And this is the mobile testing unit. And in tertiary care hospitals, there were new facilities were erected in a very short time, or conversion of existing facility in a separate building and complex to accommodate COVID patients. For example, in All India Institute, Delhi, which is a premier national institute. The trauma center was converted to COVID care facility. There's another national institute in Lucknow, the trauma center, because most traumas disappeared because there was no movement, everything completely locked down. So significant drop of trauma cases. And that's why these trauma centers were converted. In my hospital, our administration building in another complex was converted to COVID care facility. So new facilities had wards, ICUs, and ORs with separate air duct flow, AC, negative pressure environment, and so on. There are strict guidelines by the government, controlled by the government, what the criteria to open up the facilities. And there are strict regulations and monitoring of those facilities so that we did not, harm the patients and the staff. So this is my hospital. This is a building which was an administration building which was converted to COVID care facilities. We had new triage areas, and then the one important thing which we started maybe about 5 months back, the teleconsultation services for patients, and which has become a big hit. And this is going to stay because India is a huge country and we are tertiary referral center with patients coming for almost 1,000 miles to consult and operate. And after operation, they follow up and they are very, very happy that they don't have to come all the way for follow-up. Everything can be shared. We have a very robust mechanism now. All the images can be shared. And this is going to be stay with this. The major part of our follow-up consultation is going to be with teleconsultation. And many of these patients who probably don't need to come for specialized treatment can only have a consultation. We also had nursing helpline and COVID helpline. And these are some of the facilities which were newly erected in my hospital. And then in many centralized COVID facilities, we had these holding areas, suspect areas, and positive areas. The holding areas, any patients came to the hospital who were asymptomatic till the PCR test was done. They were put in that areas, and there were different PPE guidelines which were recommended by our infection disease specialist. And the suspect area was patients who were respiratory symptoms, but not COVID, because it was very difficult to differentiate one from the other. So they were in that area, both wards and ICU, till the PCR results came. And we had different complex for positive patients. And we also had all patients who had to go through a procedure or any intervention have to have a COVID risk stratifications, and we assigned a score depending whether they had traveled, they had symptoms, they had come in contact, and so on. And depending on the number, the high number or low number of risk stratification, if the patient has to go through surgery or intervention, they have to, depending on the emergency need of the procedure, they may have to wait or they have to go through emergency procedure. If going through emergency procedure and they suspect or high risk stratification, they go through a full protection and go in a COVID OR. And many centralized institutes like mine, we had a mandatory testing of swab PCR. And in current practice, we have 2 negative in 3 days for all elective and semi-elective surgery and high resolution chest CT screening for COVID. Many of these things I have learned from Franco, from their experience. We have had many sessions over telephone, on WhatsApp, and we got his advice. And many of these had been incorporated, not only in my hospital, in many centers in India. Thank you, Franco, for the advice. Currently, we are a little better off because the government has allowed gene expert, which we can get the COVID PCR test in 2 hours. Previously, it used to take 8 hours and it had to be reported to the government, and the patient used to get the report after 1 day. So currently, within 2 hours, we know a PCR is positive or not. Antigen is a screening test in the population, not in the hospital. And the another surprising thing in India, which was different from, for example, in Italy, which I talked to Franco, he said they have hub hospital and spoke hospital. Patients who are transferred to specialized center for major surgery. In India, many more surgeries were done in periphery than in metro cities. People who would probably have come to Mumbai for surgery, now they do in second, 2-tier or 3-tier cities because they can't travel, and the travel restriction and the the fear of contracting COVID. So we had SOPs for COVIDs, and we had prioritization procedure, and preferably to advise to avoid long and extensive surgery and surgery which would need post-op ICU and long-term ICU care were avoided if it's possible. So we categorized in our practice and most tertiary referral centers in neurosurgery in India to emergency procedures, urgent procedure, and priority. And depending on that, we tried and we decided whether to operate and when to operate. So for some example, in my practice, in May 20, this patient with a hypertensive hemorrhage in a 50-year-old man, pre-COVID, he would, if the patient wanted, the family wanted, he would go for a decompressive craniectomy, which was counseled and nothing was done, medical management. In April, this subarachnoid hemorrhage, ACOM aneurysm, which I would have operated in a young fellow, was sent for endovascular treatment because I didn't want to get exposed. There was a younger colleague of mine who does endovascular, so he did it. However, in October, this last month, this superior cerebral artery with subarachnoid hemorrhage, I operated because we started operating from July in a smaller scale and about 50% now. I'll give you my statistics now. Some of the tumors which we operated during COVID time, this is with bladder spinal tumor with bladder involvement. This is young girl with raised ICP and edema had to be operated. Again, young man with gross hydrocephalus and large post-fossa tumor. All were operated as semi-emergency after a COVID PCR. These are not COVID patients, but operated during COVID negative, but during COVID time. This is something which many of us are done it now. For example, we don't even have offered a biopsy for this after counseling, butterfly, GBM. There is many sequences. There is no doubt that it's a GBM, corpus callosum, butterfly, glioma. We have advised, and the family have very happily opted for no treatment at all and comfort care. And skull-based surgery, and this is the extensive petroclival meningioma, waited for 3 months before we operated in I think September end with one sitting, not to have a very long surgery, a middle fossa approach. And this was an acoustic which was with me for last 6 months, which I'm going to operate tomorrow. And endonasal surgery, we have done very few. This is one of those very few which we operated with apoplexy. And this is many of them we had following up and waiting for COVID to settle down before we plan for surgery. Now the last one which I showed, apoplexy, which we operated. This is how we operated, microscopic and with a cover on the patient and operating through the plastic sheet to avoid exposure. Now trauma, I don't do very much, but these are some of the things which we did. Emergency surgery before PCR. This patient, the boy, young fellow, had an extradural, had to be rushed in as a suspect with full PPE, and this was a subdural hematoma. After PCR, we got the test negative, we operated, and this is an acute subdural hematoma patient who had cone with pupil dilated, again counseled and medical management only. So this is over the period of months. You can see that we got January, we got the first case, but we had the lockdown in March. And then these are the numbers went down significantly in my unit. And this is how we are doing now. This is microsurgery, mostly elective surgery I'm talking of. And this is a gamma knife. We have a gamma knife facility. Again, the numbers significantly dwindled. April, we didn't do anything at all. Obviously, they can wait. We started doing it now a little bit. Many have been infected in India. We don't know the exact numbers of neurosurgeons who have been infected by COVID. And surprisingly, mostly from colleagues who had infection, not from patients, because we do take care significantly when we are the patient, but when we are with the colleagues having tea or in the lobby or in the corridors, we take off we are not on our guard, and that is how they have been infected. We have lost one neurosurgeon many months earlier in the pandemic, Dr. Simon, to COVID in India. So in India, digital was very strong. So as I said, tele-video consultation is something which we're doing and which is going to stay. I still do it now, and probably for 50 to 60% my consultation in future also will be going to tele-video consultation. Now, the another interesting thing which we have is tele-video surgical guidance to young neurosurgeon in other cities. You know, they like Franco said, it's on the mobile, and you can discuss with the surgeon, young neurosurgeon, what to do at the middle of surgery. And this is something which is very interesting and is going to, I think, going to go on. And India didn't have any of those ventilators, N95, PP, all those are now produced in India indigenously. We are not importing, and most of it are done in India. Training and teaching significantly suffered because a hands-on thing has gone down, volumes have gone down. So what we did, we started frequent online case presentation, online seminar, neuroradiology sessions every week, weekly evaluations of residents by writing, and webinars, like Franco said, many webinars with complimentary registration. These were the first couple of ones in the we started weekly webinar along with the SNSS, and these are the first one. April 21st was the one first I was involved, and this is Franco on April 28th, and the same next week. And then we had many, and these were the two very popular master symposium. We had Professor Sami there, and Spetzler and Al-Mefti. And so we still going on, and this is something new we started, WFNS Next Gen Forum webinar, the first inaugural session. Franco Sirvadi opened it, and this was on 30th September, and we are planning to have it every month, and October and November has already been done, December is already planned. So lessons learned, as you said, as Franco said, some of the things we take away from this COVID, some positive things. As I said, tele-video consult is going to stay. The patients are happy, and many of them don't have to travel, spend money, and stay in Mumbai. And meetings are going to change. They are going to be, if not completed, digital hybrid meeting, I think, to my mind, would be the way to go forward, and is going to stay. And we just realized, I realized the breaks are good. Many months I didn't operate at all. And we realized that in India, we all every neurosurgeon is very busy, 12 hours, 6 days a week. And we realized that there's more to life than, neurosurgery, operating and meetings. But this will also pass, and we'll all be back to 12-hour day neurosurgery in India, at least in soon. But we also realize there are beautiful things in Mumbai, even the pollution, in spite of the population, it's still beautiful, which I never had a chance, because we come back home in India, in Mumbai. I have never seen the evening sunsets because I am in the hospital. Thank you very much.
Thank you, Basan, for this excellent presentation about experience in India, how neurosurgery is organizing during COVID pandemic. And now I would like to kindly ask you to stop sharing your screen. Yes, and then we should try with Professor Sami's presentation now. I think now it will be successful. And we will now, of course, have a comments and discussion about your presentation in forthcoming free space for this.
I would like to ask Basant.
Yes, please.
How you evaluate the video consulting? Because this is a crucial aspect. I think it's very important, and probably we can have mistakes in video consulting. And I would like to hear your comment on this.
Yeah, there are in India. It's a very strongly regulated thing now. The government has come in, and their guidelines what you can and what you can't do in a video consult. For example, you cannot prescribe medicine. For example, some of the sleeping tablets you can't prescribe on televideo consultation. You can prescribe anticonvulsant as a follow-up. You can't prescribe first time. So there's a huge document which has been come out by Government of India, telecommunication guidelines, what you can do and what you can't do. It has to be very well streamlined, as you said. The data has protection important, privacy is important.
Yeah.
What I am doing in this thing is through my hospital, but many people are doing through WhatsApp. You know, they directly do WhatsApp directly with the patient. But in my setup, we have everything is recorded. All documents which are submitted are recorded. This is part of medical records in our hospital. So they're kept electronically record there. So if you have somebody complains afterwards, you have access to those documents and you can go back and check. So there are teething problems initially, but we are actually, I'm very, very happy because it's a tremendous support also from the hospital. We have a big group which is supporting us. And so they can, in fact, the big volumes of the MR data, angiogram, everything can be uploaded beforehand and we can evaluate.
Thank you. This is very nice for the future. Huh?
You will not believe how happy the patients are. You know, you have to, three people come 1,000 kilometers for just a consult, and they stay in Mumbai 3 days, expense involved, travel involved, and during COVID time, the fear of getting COVID in, so they're very, very happy. Most of them very happy to do that. Of course, somebody who wants surgery has to come here, but many of them would not.
It's a nice chance for the future. This.
Thank you for this conversation. And now, any other question is on the floor? If not, we can start with Professor Sami's presentation. So, Professor, not yet, Professor Sami. No, we have a when you open your presentation on desktop and then put your click on the share screen, it will appear desktop 1, and then you click on the desktop 1 and your presentation should appear. I mean, this is yeah. Yes, but I don't know what is, I really don't understand what is going on. Yeah. If you want,
you have muted, Professor Sami, you are muted.
Unmute yourself. Unmute yourself on the microphone. Unmute yourself. Yes.
Yes. Can you hear me now?
Yes.
Can you hear me now?
Yes, we can hear you. We
Yes.
see you, hear you quite well. So your Zoom is functioning excellent.
Okay. It's the same problem. I can see you. I can see everybody. And I push the green written
share screen
and come the desktop. Okay, but it doesn't video operation.
If you want, you can share your presentation with us. You can send your presentation with us, so we can play your presentation from our presentation. Otherwise, this is a usual way of functioning of the Zoom sharing.
Can you hear me?
Yes, we can hear you quite well. We can hear you and see you excellent. You just send your presentation via email or transfer to me, and then we will share your presentation from here. Maybe there is some firewall or something which is not allowing you to, or maybe your Zoom is not adjusted to this activities. I don't know what would be else the problem. Well, Professor Sami, yes, now we are seeing you turn on the camera. So maybe if you want, you can share the presentation, or you can speak without presentation, however you like.
Can you see my screen?
No, so far no.
Can you
yes,
hear
we
me?
can see and hear you excellent. So you can speak without presentation if you want, or you can share your presentation with me, and then I will play your presentation from here, from our administration, however you like.
Yeah, okay. I cannot. Unfortunately, I don't know what is happening. You know, Lukas.
Yes.
Do you know what I do? I shut down and open again. You know, this is probably.
We will continue, and then you connect again, and then that's okay. Perfect.
Exactly. This is the only way. Otherwise, there is something wrong. I do it always the same, but it is not working. Yeah. Okay. I shut down and start again.
So you disconnect yourself.
You can start with
yes.
the next speaker. Yeah.
And then you connect again. Then we'll continue. Okay. We continue with Professor Francesco Tomasello, honorary president of World Federation of Neurosurgical Society, and distinguished neurosurgeon, professor of neurosurgery from Messina, from Italy. And then now we are seeing your screen. Please continue with your presentation. There are many titles and honorarias that Professor Tomasello earned so far, but the most important is we are all friends, and this is the best presentation. What I can say, that we are all friends and supporting each other. Professor Tomasello, just turn on your camera and turn on your microphone.
Yeah. Can you hear me, Lukas?
Yes, we can hear you, but you can turn on your camera, please, if you want, of course.
Of course. Excuse me.
Just turn on your camera, and your microphone is on, your presentation is on the screen, everything is fine.
Now it's, excuse me.
Just,
okay. Everything okay.
Now it's excellent. Now it's excellent. Perfect. Excellent. Okay.
Thank you so much, Lukas, for your kind introduction. And I thank you so much for this kind invitation. And I thank the Serbian Society because we can share our ideas and our experience on this terrible time of COVID-19. I will focus on the aspect of the neurosurgical resident training, which is, I think, very important and was mentioned by Franco Servadei and by other speakers. I can't go on. I don't know why. Okay. We saw that there were many papers published this year on the problems of the coronavirus and the virus and the neurosurgery. Also, our group contributed with focusing on societies, neurosurgical societies' recommendations. The Neurosurgical Scientific Committee, as the conclusion was that the the scientific community has promptly reacted to the COVID-19 outbreak by producing a growing number of documents that could serve as guidance for neurosurgeons all over the world. The neurosurgical societies represent the key institutions for guiding the neurosurgical community to overcome the COVID crisis. Of course, this situation caused a rapid change in neurosurgical education. This is a sentence already mentioned by Franco Servadei: necessity is the mother of innovation. The pandemic and related restrictions, above all in elective neurosurgery, are producing significant effects on neurosurgical training programs and residents. As we saw already, a significant reduction in operative cases, work hours, and exposure to outpatients. In this situation, how does a program adapt education rapidly? And as we saw, utilizing virtual platform to offer educational mentorship opportunities and simulation labs. But the theoretical education was growing up while practical training is a little bit down at this time. Many papers also on the aspect of neurosurgical resident education. This contribution already mentioned by Franco Servadei, demonstrating that there was a decrease in some cases as glioblastoma and meningioma, but there was no decrease in emergency neurosurgical procedures. So the British perspective on this aspect, the COVID, the conclusion on educational impact, the COVID has affected multiple streams of neurosurgical practice beyond a significant reduction in conventional training opportunities. The national advocated social distancing measures have led to the cancellation of departmental educational meetings, subspecialty multidisciplinary team meetings, and outpatient clinics. So the neurosurgical residency programs had to consider the long-term effects on resident education and develop an internal roadmap moving forward on this aspect. So we know that the pillars of a neurosurgical residency program are training and education. In the United States, in a survey of 57 neurosurgical residency programs, was demonstrated there was a reduced number of residents in hospital, 94%, and reduced the number, especially of residents scrubbing, 47%, and as we already saw, redeployment to other services, 14%. A survey was organized and planned for Italian neurosurgical residents, and the respondents demonstrated there was a reduced working hours in hospital, 63%, and a reduced surgical activity, and for some of them, management of COVID patients. In the United States, an action plan was proposed for this situation. The two residence group, 1 week on and 1 week off, rotating every 7 days. Week on group, 1 resident in each operating room for day, no participation to endoscopic and nasal surgery, and in the group week off, online lectures, academic work, and backup team. The same was proposed for spinal surgery, and some papers on the North American Spine Society and the Orthopedic Society demonstrate that this action plan can be working. So definitely this is an Italian contribution to this aspect, a step toward a new era of educational training, question mark. E-learning, of course, was very important in these months, online meetings, simulation-based training with also virtual and augmented reality. The CNS, the president of CNS, stressed the fact that CNS volunteers and staff developed 2 new programs to help resident members stay connected and continue their education in innovative new ways and, of course, free of charge. In the Congress, they organized the CNS virtual visiting professor, interactive, and online grand rounds with recorded webinars. The same with the WNS, with online courses, webinars, and so on. And similarly, also the European Association with the e-learning, with the programs of e-learning, which were appreciated by the residents. In Italy, the Department of Neurosurgery, the residency program of the University of Messina, promoted a nationwide online network for neurosurgical education. And 331 residents belonging to all Italian, 24 Italian residency programs were involved in the network. There were presentations by the residents and discussion on neurosurgical.
Hello, Lukas.
And
I hope you know what happened. I have found what was the problem.
We hope so, Majid. We hope that we can find the solution. 30 minutes presentation followed by discussion with faculties. This initiative started in April, last April. And after 5 seminars, the participation of almost all residency programs in Italy was recorded, 23 out of 24, with a progressive increase of residents' participation up to 87% of all Italian residents participating on the online educational network. So this was an initiative which was really very appreciated in our country. But of course, we have to mention, and it's impossible to mention, all the webinars organized with educational impact for young people around the world and in all continents, of course. But what about practical training? We use it, of course, we continue to use educational platforms, but we have also some simple physical models which can be utilized, and more sophisticated optic computerized simulators. I would like to only to mention some of these platforms. One is the Neurosurgical Atlas, which is a collection of texts, intraoperative images, illustrations, and videos, which are very important to learn some technical aspects. Another one is the Brain Book, created in United Kingdom, is a platform created to facilitate a neurosurgical case-based learning, and it was also published very recently. And the last one was mentioned by Franco Servadei, was supported by the World Federation Young Neurosurgeons Committee, is an app surgeon designed to improve theoretical knowledge of neuroanatomy and neurosurgical procedures. This is one of the possibilities in the international scenarios. But there are also already published in the last years some simple physical models to train young residents. One of these is a realistic model for brain tumor resection. There are some also simple models for endoscopic endonasal drilling technique, which can be used, of course. And another aspect should be the cerebrospinal fluid leak resolution with a model of spinal dura mater. And the same for anterior cervical discectomy and fusion simulator, which can be used with very simple tools. And going on with the more sophisticated technology for simulation with the virtual reality and optic interaction, articulating arms or tactile sensor for tactile interaction with the virtual environment. The simulation scenario include the bulking, hemostasis, and microdissection. And what is very important, with optic feedback. This is the aspect. Of course, this sophisticated technology is expensive. So we need to concentrate in hub centers this technology for for benefit of residents. This is the Italian Center of Besta Institute in Milan, and this is the simulation of aneurysm clipping in the reality and in simulation. And there was also a link between the Besta Center in Milan with the Geneva Center with Karl Schaller, and they evaluated the performance of a very simple procedure as external ventricular drain on a simulator, and they demonstrated that this correlates with the density of neurosurgical experience for that specific task. So this is the lab in Geneva with some training for microsuture and for other procedures. But also for example, in the United States, there are centers for virtual reality and simulation in neurosurgical training, and with different facilities for this. But the problem is what are the drawbacks of simulation and what are the advantages? The advantages is especially over other educational algorithms, such as apprentice program, in that the simulators provide training in a specifically fabricated and controlled setting. This artificial environment offers the training an opportunity to be placed in difficult clinical situation. It's not difficult to understand that, for example, the webinars on complications in neurosurgery were so popular and so well attended in difficult clinical situations that often mimic a crisis. The training gains clinical experience with no risk to potential patients. But virtual learning, we are now, and I agree completely with the speakers, the previous speakers, that virtual learning is a very important chance in this difficult time. The novel solution demonstrates several benefits, especially this challenging time, and will remain. We are sure that we will have meetings in person, but we'll have also a better scientific communication, a better educational communication through this new communication tools. And we are sure that virtual learning will remain a significant educational adjunct after the end of pandemic. Virtual learning, however, will not bridge certain gaps. The virtual platforms cannot address the lack, which is very important for us, of intraoperative experience. The residents complain about the decreased time spent in the operating room, refining and practicing neurosurgical techniques. To conclude, in this dark time, the moonlight of virtual education looks good and beautiful. And this is our hope that this innovation can contribute to the growth of neurosurgical community around the world. Thank you so much.
Thank you, Professor Tomasello, for this excellent presentation on the very important topic such as neurosurgical resident training at the time of COVID-19, and this is a worldwide experience. I would like to ask you to stop sharing the screen so we can continue with our further presentations and discussions. If anybody would like to give some comment or make a question about this presentation of Professor Tomasello, please. There is also no suggestions or comments or questions on the chat. I would like to welcome Dr. Andreas Demetriadis, President-elect of European Association of Neurosurgical Societies, our friend who is also connected now. And if we are ready now for Professor Sami, please turn on your microphone, and we are waiting for your presentation.
Dear Lukas, it still doesn't work. Therefore, I will give my, the problem is that I have a new software on Friday in my computer, and therefore probably due to complete change of my software, the Zoom has some problem. They have not updated, and therefore it will be a problem. But I will give my presentation, just you can see me, and I will talk about my personal opinion about our topic. And I have only to have my presentation in front of me, and okay, but you can see me, yes?
Yes,
can you see me?
Yes, we can see and hear you quite well. I mean, perfect.
Wonderful. Okay. So I think, my dear Lukas, first of all, I would like to thank you for the opportunity to talk on this very important topic, which is probably not only related to neurosurgery, but change our life totally as this virus started, and we the problem is that we are facing completely another life in the history. Perhaps we don't know what happened in the pandemics in the past, but at this time, with the new world, a new digital world, then this pandemic has changed everything. And neurosurgery is, of course, a part of that, that we are dealing with that. And I would like to start a little bit about the history of COVID-19 in China. Started and but at that time, as we heard about the first cases in China, nobody could imagine this virus would in short time reach all other countries worldwide. The question which we have to ask ourselves, why the virus was able to extend so rapidly throughout the world. European, American, and Asian countries were very relaxed and didn't start anything to protect themselves. Everybody believed, it is a Chinese problem. They will solve it. It has nothing with us to do. In European countries, the reaction of government and people were in beginning from country to country, of course, different. Once we have seen that once one single traveler from China who reached Germany and has transferred this virus in a short time to a large number of people, still the responsible people of healthcare system in Germany, as well as some other European countries, in the beginning believed the virus could be managed in an easy way, like influenza or other viruses we have in the history. For that reason, in relatively short time, there was an explosion of infected people. Franco has demonstrated the situation in Italy. Italy was the first country with enormous number of infected patients and high number of patients who died by COVID-19. In Italy, in short time, all existing ICU beds were suddenly occupied. There were not enough intensive care beds available for everybody. As a matter of the fact that the number of severe complications such as pulmonary infection started to increase more and more, particularly in elderly population who needed intensive care beds for respiratory treatment. Suddenly, the capacity of healthcare system with ICU was at the limit. I remember Franco and Francesco, many of my Italian colleagues, when they talked to us and they said, we have an ethical problem, how we can make a choice between all these patients who all needed respiratory assistance. This situation in Italy was a shock for all other European countries. For that reason, Germany and other countries decided to lock down of social life in order to avoid the situation in Italy. The government stopped any kind of elective surgeries. This is, of course, a very strong order. Surgeries which needed post-operative intensive care. I remember that our Minister of Health gave order, they will pay 50,000 euros for every hospital when for each single intensive care bed as supporting for increasing the number of the beds, that we will not have the same situation as in Italy. That was in all hospitals in Germany. For increasing the number of available intensive beds to treat corona patients, only urgent cases have been accepted. All vascular tumors and complex cases have been refused. Also, no, all neurosurgeons in Germany were not allowed to do any elective surgery. And you can imagine people with brain tumor, with beginning of herniation, or the vascular cases with aneurysm rupture and so, and they have to discuss, should we operate or not? It was a complete lockdown of neurosurgeries in all in country, in Germany. And with the first, of course, lockdown in Germany in the spring, the government have been very successful in reducing from day to day the distribution of coronavirus until the infection rate reached minimal incidence value, less than 50 cases per 100,000 population every week. And that was, people were very happy, and we could start again with neurosurgery, and the hospitals were opened and for neurosurgical cases. But still, many patients for elective neurosurgical cases, they were afraid to go to the hospital and to be operated. They postponed. I remember in August and in September, every patient who had an appointment for surgery, they call on and say, I want to postpone my surgery for a couple of weeks later. In summer, finally, the government could come back to normal social life with some restriction. Of course, these restrictions and the time that we had the restriction and this improvement of situation, this result has been achieved with a high economic price for more than 80% of middle and small companies, institutions, restaurants, hotels, and all other facilities. Even some small hospitals, despite of enormous governmental support, many companies became insolvent. Beside of the economy, one of the very important aspects of the coronavirus was and is the psychological aspect. Due to all restriction in the hospital, the relatives, visitors, and friends are reduced only for one person. The grandchildren are not allowed at all to visit grandparents. We could observe in the hospital that this isolation by many patients had negative influence on their motivation for post-operative recovery. After the general lockdown, with still some restriction was over, as I told you, the neurosurgical life and activity was as normal as we had before. Unfortunately, in October, the number of new infected patients were increased. The government has again ordered a lockdown for whole November. Yesterday, the lockdown has been extended until New Year. The government had a strong meeting on Thursday, and yesterday by television or newspaper, they gave the next order, very stronger than before. And in case the number of new infected still are not acceptable, they said yesterday, that the lockdown will further extended. We are now in the middle of the second lockdown in Germany. All experts are working on how to manage the situation. In the last 2 weeks, we received, of course, from different companies, information about reliable vaccine. The government of some countries are planning to start officially in December. The question which we have to put on the table is what we have learned up to now this year. Because we have a not visible enemy, and how we can eliminate this situation for future. We know all 100% protection of coronavirus is not existing. You see, all the things have a distance and washing the hands and washing everything every day and have a mask and many, many, many other things. These are wonderful. We can protect us, but at the end, it is not completely solution for the social life. What is my personal analysis about COVID-19? I say that as long one single infected patient with coronavirus is able in a very short time to transfer this virus to around 100 other individuals, this is something we have to take very seriously. And that means we must be ready to live with this virus forever, as we are living with influenza and other viruses which every year, particularly in winter, they reach us. The development of vaccine will, of course, be of great help, but not complete solution for COVID-19 virus. Our neurosurgical societies and activities has to be adjusted, as we heard from former speakers, considering avoiding and protecting us and our patients from risks of corona infection. We will probably avoid the next future any international event. And the telecommunication system will become more and more very significant for scientific exchange and education. My personal opinion is that we should try to ask the virologists. Their time is over. They told us what we have to do with the virus. But at the present time, the problem is more the social life and the intercommunication of human beings, the family, the friends, and the society, And therefore, I believe it is the time of all experts and scientists of social life in our countries. This is the time they have to sit and discuss how we can avoid the collateral damages that this virus has brought through the society. How the society can come back a little bit to the normal life. And there are so many aspects of the collateral damage in the they need to be considered, and the government has to pay as much money as possible also to solve this problem among all us in all over the world. This is my personal opinion. Thank you very much for your attention.
Thank you, Professor Sami, for your talk, your lecture, your presentation, and your advices and opinion is always very, very valuable for all of us. And is there any comment, question, or any kind of conversation continuing the Professor Sami presentation, lecture?
I was impressed by the presentation of Professor Sami, and I would like to stress the last sentences of his presentation, because there is a need that there is a unique voice in the scientific world of virologists and other specialists, because the suggestion of Professor Sami to have new ideas for the future social life is very, very important, because I agree with him that probably we can solve the great problem of disease, not completely, but we can solve to some extent this, but we can't solve the diffusion of a virus in the future. So it's important that our change in social life and also in professional life can be modulated according to the indications of the virologists and of scientists involved in this important research. I think that Professor Sami gave us a very important suggestion on what we need to care for the future.
My dear Francesco, in the recent time, many books have been published about the virus. And it was interesting, one point that I have not mentioned, that one of our virologists, very famous in Germany, published just 2 weeks ago a book, and he said that he is convinced that the primary virus, which came from Wuhan, as it came to Italy, it has become a special mutation to become a very wild virus. So he believes that it is not the same virus. It is originally is the virus from Wuhan, but it has been changed in Italy, and therefore Italy had such a unbelievable disaster with distribution of the virus. This is, of course, it is his theory, you know, but he said that this virus has been then extended in other places. What I said about the social life, believe me, Francesco, the people are suffering more from isolation and being alone and not being able to communicate with others than the virus. Believe me, this is something that we are now looking at the virologists, what they are telling, how we can protect the people. It's okay. But who is taking care of the people that they are suffering? I know from some countries, let me say one example, from poor countries, the father did suicide. Why? Because he was not able anymore to earn money for 3 children and his wife. Not only 1,000 in the meantime. We are privileged in a country that German countries, governments say, we are going to pay about 300, half a billion euros to those restaurants or whatever they are suffering not having a customer, you know. But what happened to the others? Therefore, we must be aware about that. We should have in future meetings about the collateral damages of human being through the COVID 19, you know. And this is my analysis after I have seen what happened in all over the world. And that is the reason, and I am thank you. I thank you very much. I'm thankful to you, my dear Francesco, that you received my message. I hope many other people will receive this message as well. Yeah. Thank you.
Thank you, Majid.
Professor Sami, we all receive your message well, as always. And also on the chat, you have congratulations for your speak from Nadia El Abadi from Morocco to you and to all previous speakers. So your messages are always important for us. And I'm very glad that your messages now is distributing via YouTube. So a lot of people are looking that, and a lot of people are looking. I will tell you at the end total numbers of all participants, but so far so good. We have to move on. Thank you very much for this outstanding presentation. It's my pleasure to announce Dr. Professor Van Teusou, who is the president of Australasian Society of Neurological Surgeons, and he is now with us. He will present experience of the impact of the COVID-19 on neurosurgical education in Singapore and beyond, so Far East experience in fighting with COVID. Thank you, Dr. Van. Please continue with your presentation.
Thank you very much, Dr. Lukas, and good evening to everyone. Yeah, so this has been quite a fascinating talk so far, and I thank all the speakers, Professor Sami, for whatever they have shared, because these are very important to all of us. So I'll speak on what's actually happening in Singapore, and then see whether I can go a little bit further than that. So actually, we had our first case in this on the 2nd of January. They started alerting us, and on the 23rd of January in Singapore, we had our first case. And actually, in the early part of February, actually, we had the highest number of COVID-19 cases outside of China. And then, of course, the pandemic was declared in March. And actually, we were actually prepared for an epidemic like the pandemic like this, because we experienced SARS in 2004. And actually, one of the things that the government had decided to do was to actually build a center for infectious disease. And very fortunately, this center was opened in September 2019, just like 3 months or so before the SARS case. And of course, in that case, it became the Center for Outbreak, headquarters. And then, of course, the other public hospitals were also prepared for admissions. We have a disease outbreak response system condition that the government had actually put up. And of course, in most of the time, it's green. When we had the first case reported outside of China, it became yellow. And then when the number of cases started to happen in Singapore, we were what we call DORSCON orange. And so when you had DORSCON orange, basically what happened is that this was it was raised, and then once it starts having DORSCON orange, a lot of things were put in effect. This was what was happening that time of the year. So by the time we had about 33 cases in Singapore, we were raised to DORSCON orange. And what that means is that there was already screening in community hospitals, target testing of suspected cases. Then as soon as you find a case, there's extensive contact tracing. And Singapore is not big, so this was something that was done fairly easily. And of course, we had the quarantine, what they call stay-home notices for people who were either exposed to those with infection or were coming home from a high prevalence country with social distancing measurements, and then of course free diagnostic testing for those who were treated, had infection. And of course, even the entrances to the hospitals were actually closed up. Only 1 or 2 areas were allowed. And then you had temperature screening, the alert for travel. And then if anybody has a fever or signs of upper respiratory tract infection or pneumonia, they were isolated and then they were sent to the NCID, the Infectious Control Center, for testing. And then of course, under DOSCON Orange, also even us, because like the hospital where I work in, we actually cover several other hospitals, and we may move from a hospital to hospital, but the movement was restricted. We were all put into separate hospitals and were told to stay there, all right? And then, so that includes, and only the tertiary hospital actually had subspecialty coverage for neurovascular, skull-based neuro-oncology. Those regional hospitals were focused mainly on trauma and spine. Although it was necessary, we would transfer those patients in the hospitals to the main tertiary centers. And of course, our elective surgeries were put on hold. We actually had to review the surgeries, and non-urgent cases were postponed. We were still able to do some semi-urgent cases because the NCID was actually able to take the initial log of cases, all right? But then we actually had to make sure that, we were reviewing all the cases and so forth. And at that time, it was a controversy regarding endonasal surgeries because doctors who were operating on patients endonasally were actually kept contracting COVID-19. So we actually put that on hold until we were able to test these patients. Of course, we had to cut down our outpatient clinics and so forth. And then we also moved towards teleconsultation, but this only for those cases that were simple. For instance, you've had scans done, we were able to contact these patients and then discuss about the scan results. But new cases had to come to the hospital. Of course, our education meetings were also quite limited because of the inter-hospital movements restriction. So we couldn't move from one hospital to another. Normally, we meet every week in one of the hospitals for our departmental meetings, M&Ms, journal clubs, and resident tutors. So this will all, we couldn't come, so we started then using initially WebEx and then subsequently Zoom. And of course, you can see, maybe at any one time in the main room where we used to crowd, only 2 or 3 people were there, the rest were on Zoom, right? And then in April, because the number of cases started to increase, we had a lockdown, we call it the circuit breaker, all right? And so in those cases, basically all the shops were closed except those supplying food, supermarkets, clinics. There's all the restaurants were not closed, but you could not go in to dine, only take away. Schools were closed, and then office workers in non-essential services had to work from home, right? And of course, we had to wear masks and so forth, right? So this was some of the things that we had to do, okay? And then after that, 18 June onwards, the government started to reopen because the number of cases were dropping. So they allowed 5 people maximum to gather together. So the restaurants open, and any one time maximum of 5 people per table, which was separated away. Shops and all that started open, but then every time you go into a shop, you actually have to do a contact tracing. Either you scan a QR code from your phone to say that you were there, then you switch it, or you turn it off later on when you leave the shop. Any building that you go into and all that had this type of a thing. So we had, on my phone, I have the QR code reader, and I'm using it quite often. Even when I go to the hospital, I actually have to turn on the QR code. So this is the number of cases that happened. So initially, as you can see, in February, we actually had small numbers, and then suddenly went up. And this was because the dormitories, we have about 300,000 foreign workers, mainly from India, Bangladesh, and other parts of Asia, who come and work in Singapore, and they actually stay in dormitories. Dormitories are actually quite packed. And so when we had 1 or 2 people getting infected, the whole dormitory started So actually about 2/3 of the people in the dormitory actually caught the infection, but because they were young, so many of them did not actually have to stay in hospital. So they were actually nursed outside in the stadiums and converted areas. That's what even Basan said for what actually happened in India, right? So some of them stay in army camps. We converted a big this convents area in Singapore into these dorms, the places for the dormitory workers to stay, and then they were separated and so forth. So it took a long time, quite a while to control them, until finally things start to settle. And by about end of July, actually the number of cases were actually coming down. So these were the dormitory cases that you can see. All right, so once they were quarantined, isolated, and so forth, then the numbers starting count. So now you can see in Singapore, the number of actually communicators was actually virtually down to 0. What we're having is the number of cases that are coming back, Singaporeans or families of workers coming back to Singapore from other countries. So these are all quarantined, and then they stay for 14 days before they are tested twice. And then, so we still get some of these, what we call imported cases, but the number of cases in the community in the dormitories are actually almost 0, right? So if you look at what's actually happened now, like today, all right, 6 new cases, of which actually mainly were, one of them actually from yesterday was a community case, but the rest were imported. We actually have had up to now 58,000, almost 60,000 cases, but we actually have very, very few deaths. And I think because Singapore is near, many patients actually, get to hospital very quickly and are treated. So obviously it has affected our surgical training and education, right? So the cancellation, the overwhelming part of the hospitals and ICUs initially, or they were being prioritized, so they were closed for electives, right? The patients were afraid, obviously, to come to hospital, and then reduction of hospital cases. So some of our residents and trainees were redeployed to other parts to help up with the other services, especially when the dormitory cases were there, right? We had wards there for COVID patients, ICUs. We used some of the residents actually had to go and help with the swabbing and testing because we're doing a lot at one time, right? We're doing about 200,000 tests a day. And then provide medical care to the quarantine centers and the dormitories. Obviously, we had some cancellation initially, but I think one of the problems was that actually there's much less interaction between our trainees and their consultants because many of us were not in the main hospital where the residents were, right? We are not allowed to travel for overseas meetings, conferences, and so forth. And then for our final residents, they were not, the examinations, which was supposed to be held in April, this was initially postponed and then canceled. And probably next month is when the examinations will be held. So these few of them, they cannot really progress on in their training. And of course, I think as we have heard from Professor Savadari and everybody else that, there's the main thing that's affecting our resident training is the reduction of elective surgical workloads because of the way hospitals are doing to try to safeguard healthcare systems and so forth. And right, of course, the other thing is patient encounters are reduced. And then, of course, in many places, tutorial teaching sessions and so forth are either less held commonly or are canceled. And of course, interactions with the teachers have been reduced. So for us, actually, as you can see, the pandemic has not affected us in Singapore as much as it has done and still doing right across the world. We actually, apart from the number of cases that went up in the dormitory, we actually don't have a second wave in the community. Today in Singapore, most of the shops are open. You can still dine in, although maximum 5 people. We have to wear a mask wherever we go. Now, especially the second part of the reopening, a lot of the centers, even the museums and cinemas are open, but you actually, like for instance, to go to a park, you may have to register. They meet only a fixed number of patients, of visitors, not everybody you can crowd in, right? So it's a slow and gradual opening up of services. Our elective surgeries actually have resumed. Our outpatient clinics back to 100%. All right, our trainees after a 5-month ban of rotation have now started to rotate again. And so for the last 3 months, we're actually back to 100% in terms of elective surgery and outpatient clinic. Right, our departmental meetings comprising mortality, morbidity sessions, pre-surgical case discussions, journal clubs are back to our weekly routine. But again, it's a hybrid where some people are sitting in the room, but many of us are actually coming in online via Zoom, right? Our resident tutorial is also hybrid, and we started a month ago. And then the final examinations, as I mentioned, next month will be physical OSCEs with external examinations from the College of Surgeons Edinburgh and from Hong Kong, because our residents share the same exam as the neurosurgical residents from Hong Kong. But of course, one of the spotlights, as Professor Vadaris mentioned, is the number of Zooms, all right, webinars that's been around. And one of the things, as somebody from the Asia Australasian region, is we're very happy to say that a lot of these Zoom meetings actually have originated from Asia, all right? So I think you can see, right, Basan has been very, very active. Right, so we've actually had all this already in March and April, May, June, and so forth. Let me just go. So, right, so there are so many of this that has happened, including the WFNS, and actually even in China, right? Professor Bin Su from Shanghai has been very active. What he has been doing is actually some of the webinars that are outside of China, he actually put them on Weibo, and then actually this is transmitted across the Chinese neurosurgeons, and the attendance is amazing, usually more than 1,000 or 2,000 attendees, right? So there are also webinars from Europe, and actually Professor Saman Sharif from Pakistan actually has been running a lot of Zoom he runs the Zoom sessions for the FNE and so forth. Right? And of course, I'm also a member of the International Society of Pediatric Neurosurgeons. Instead of having webinars, they actually have been having debates, which are actually very, very interesting. And of course, we also have had this free virtual meetings from the ENS and the ISPN, which has been very, very good quality. And of course, the Asian Oscillation Society have not been lacking behind. We also have run a series of webinars on topics that are not so talked about in the various webinars, and usually much more general thing. But also our colleague Professor Sinha, who is also in charge of the neurotrauma committee, has been running the neurorehabilitation and neurotrauma webinars with the WFNS. And then one of the things we realize is that there's so many webinars, but not all the webinars do not really cater to the lower level trainees. So we decided to do a couple of boot camp webinars, all right, looking at the fundamentals in neurosurgery. The topics were actually given by the residents themselves. We asked them, so when you joined neurosurgery and started as a resident, what were the areas that you had problems with? Is there a topic they can suggest that we could run for these boot camps? And actually they came up with the topics, and then we asked them to, why don't you make the lectures, create a presentation, and then have one of our consultants go through with you to make it better. And I think this is what we've done. They've been very successful, and hopefully we'll have a few more in the coming year. Of course, actually, I have to give credit to this person called John Bennett, who's the person who created Neurosurgical TV. The Neurosurgical TV, I think, is one of the channels that actually has been pushing a lot of webinars all over the world, from Asia, from the Middle East, from Latin America. Right? So John's actually contributed a lot to actually our webinars. And of course, as mentioned earlier, the Neurosurgical Atlas is an area where at least residents can use as a resource to look at operative videos, because if you have lack of theater experience, at least watching the videos and listening to someone tell you how they do it and why they're doing it this way actually helps a lot. So obviously, virtual meetings are the way to go, right? They can expand it across the whole global audience. They're much cheaper to run. They can be engaging. They're flexible, variable. I think a very important thing is the extended life of content, because You can just put them up on YouTube, and then people can go over them anytime they want, right? And basically, you can also with with Zoom, you can track and measure the reach and impact, and of course, low impact on the environment. And so they're definitely here to stay, all right? But the only thing that is a problem is actually real surgical skills, right? I mean, expertise does not happen. You need to spend time doing this operation over and over again, every time learning slightly different things to actually make you a very good surgeon, to be an expert, all right? And so the most important thing is therefore the need to train surgical skills. Now, in the days when you could travel, and this is the neuroendoscopy course that the IFNE hosts in Naples every year, right? You can learn, and you have not only just learn, but you have teachers teaching you, right? But with the coronavirus, okay, even planes are on sale, we can't travel anymore, right? And so people talk about using simulations, and I think we had a big discussion. Professor Tomasello talked about that. And it started off with the general surgeons look for laparoscopic training, right? In the endoscopy, you can actually have all these models. And there are even new models that have come out for us to try out, right? And even models of brain, as was earlier shown. But the problem is many of these models are not easily available. If they're available, they're expensive, but they're not really realistic in many times, most of the time. They're not representative of anatomy or the procedure, or if you wanted, there's no such simulator available. We talk about virtual reality systems using haptic, high definition video screens, high fidelity, even the introduction of artificial intelligence. The reality is that the technology is not there yet. So we don't really have currently good simulation models, whether it's physical, electronic, to train neurosurgeons. So we just have to wait out this pandemic, at least for now. But the wait might not be much longer, as you can see, like this was in our newspaper today, talking about the vaccine, would you get it or not? I think if there's a good vaccine, I would definitely go for it, because I'd love to travel. But I think during this time, aside from the educational conferences, that take sessions that we have in neurosurgery, we could do other things. For instance, in Singapore, currently running a medical doctor seminar law or the health law, right? There can be time spent learning about ethics, about improving your communication skills. I think we still have to invest in virtual platforms for sure. If you don't have one, YouTube, Vimeo, Vilmedi, we can share resources and activities, look for opportunities to develop and expand. And I think many of us have been doing that. And Basan's been really great running many of the courses with the WFNS, right? And, we just need to expand and our teaching and testing of the surgical knowledge, diagnostic and therapeutic approaches, both oral and written. So it's not, it's not that we are stuck. There are many things we need to do. But last but not least, I think we need to be also aware that actually a lot of our trainees' well-being and mental issues have actually gotten worse during this pandemic. I think Professor Shamli spoke of isolation of families, but even our residents actually get isolated because they are not sure about their future. They may have spent more time training. They're aware of the fact that they're not having enough training. Many are deployed to non-surgical roles. Even those who are there fear that they may contract COVID-19 and they could pass it on to their family members. So they are actually having a very high burnout rate. So we should be on the lookout for those in trouble, and they would need to be helped accordingly. So hopefully many of you will be able to come to Singapore in November next year to join both the ISPN meeting and the IFNE meeting. Right, these are going to be held concurrently so that you don't need to come twice, just once is enough. So I thank you for this opportunity to talk. Thank you very much.
Thank you, Professor Van Theo, for this exciting presentation. We are all sharing, as I can see, and also we can see the same experience, similar at least during all this period. And I think this is important that we can realize that the situation is similar worldwide.
Yes.
Any comment, question? And of course, we will highly like to come in Singapore.
Yes.
Looking forward to it. Is there any question, comment on this lecture?
I'm having a comment, if you hear me.
Yes, Ron, please continue.
Yes, I heard here the amazing data that there was not a second wave of epidemic. So my question is, because it concerns medicine indirectly, did you have a border closure? Because
Absolutely.
I know that in Taiwan, everyone has to have a 2 weeks quarantine. How did you manage that there was no input of COVID cases to Singapore?
So I think the border closures happened once we started. I think everybody realized that there are many cases coming. Initially, we were not stopping them, but after a while, everywhere around the world, I think by March, Singapore was in also lockdown as far as entry is concerned. I mean, we allow people to come back. If you're Singaporean, you can come back. If you're not a Singaporean, but you're working in Singapore, you have long-term pass, you have family, people who need to come back, they can come back. Although now it's a bit stricter. We also get a lot of medical tourists, people who need medical care. They come to Singapore for medical care. Initially, we're allowing them, but afterwards, we actually stopped also because there were patients with COVID who actually traveled to Singapore to get COVID treatment. And the government felt that, it's nothing that we could not do. So yes, our borders are closed. And it's very hard for Singapore economically because Singapore is it's a travel center, a travel hub. People going to Australia, from Europe to Europe and coming back to, you can come to Singapore, then you go to other parts of Asia, Southeast Asia. So that's all. The airport's been closed. Only in the last month, now we're getting some flights out. But we tried to have what they call a travel bubble with Hong Kong, but this was canceled at the last moment when the number of cases in Hong Kong actually went up. So most of the new cases that you find in Singapore are actually from people who are coming back to Singapore and they are on quarantine for 2 weeks. They are tested just a few days after they come in and then just before they finish their quarantine.
Thank you for this comment and explanation. If there is no more further comments or questions, I would then like to proceed to continue with our next presenter, next lecturer from Africa, from Egypt, Dr. Nasser El Gandour, who is our great friend, and he will present impact of COVID-19 on neurosurgical education in the African continent, as well impact on neurosurgical practice. Thank you. Thank you, Nasser. Please continue.
Thank you very much, my friend Lukas. First of all, I would like thank you for this kind of invitation to be in this session among the eminent neurosurgeons, Professor Majid Sami, Franco Servadier, Besant Mishra, Francisco Tomasello, Marco Fontanello, and all my friends. It's a great opportunity, and I would like to congratulate you for the perfect organization. Let me just first try to share my screen. I don't know if I'm able to see my full screen.
Yes, yes. Continue, please.
Okay. Thank you very much. My talk for today will be about the impact of COVID-19 on neurosurgical education, both globally and in Africa. The COVID-19 pandemic has affected all aspects of human existence with social and psychological repercussions that generations have not witnessed before. As the virus is projected to afflict large portions of the world population, clinical research at all levels has been suspended. Clinical articles have been replaced by reviews and surveys. conferences have migrated from classroom to the digital screen, and this is what we call it virtual learning. With this major change in the method of education and with the eruption of the virtual learning as a new method for education, many questions arise. Is virtual learning effective as in-person meetings? What are its limitations? Is it possible to develop clinical skills through virtual learning? What is the opinion of neurosurgeons about this new platform? Is Q&A communication equal to face-and-face communication? Is it a turning point in neurosurgical education? What is the impact of this technology on on-site meetings? Could virtual learning totally replace in-person meetings? And what about expectations for the future? In order to be able to answer these questions, I was honored with my team to publish a global survey, and I was honored to join young African neurosurgeons and to contribute in a continental survey concerning Africa. Let us first start by the global survey. Survey was sent by emails, distributed through social media. It was translated into 7 languages, administered through Google Forms and WeChat. We used standard statistical methods. And one of the advantages of this global survey, which is not available in all other surveys, is that it was possible to do a multivariate logistic regression analysis. We received responses from 891 neurosurgeons from 96 countries, 165 of the respondents from Africa. We used the World Bank classification in order to categorize countries according to income into low income, low middle, upper middle, and high income. This bar graph shows the different percentages of participation in the survey among these categories. We also used the World Bank classification in order to categorize the countries according to location into North America, Latin America, Europe and Central Asia, East Asia, South Asia, Middle East and North Africa, and Sub-Saharan Africa. And as you see, this is the incidence of participation from the different categories in this global survey. This shows the incidence of participation in the survey according to practice setting. Academic neurosurgeons constituted 48.5% of participation. This shows the incidence of participation in the survey according to the specialty. This shows the incidence of participation in the of faculty and trainees. Faculty constituted 46.9%, whereas trainees constituted 53.1%. This survey it depends on 3 main components. The first one is virtual learning before and after COVID-19. The second is opinion of neurosurgeons about this shift to virtual learning. And the third is the future of virtual learning. Let us start by the first component, which is a comparison before and after COVID-19. This shows the incidence of participation in visual learning. Before the pandemic, it was 44.9%, whereas after the pandemic, it became 78.3%. This shows the incidence of paying fees in virtual learning before and after. It was 14.7% before the pandemic, and it is 10.5% after the pandemic. This shows the distribution or according to the organization, the webinars which were organized by international organizations had the highest incidence of participation, 63.2%, whereas webinars organized by local organizations, the incidence was 49.8%. The second component is opinion about shift to virtual learning. Could the virtual learning totally replace on-site meetings? In 32.9% of participants, they said yes. whereas 54.7% they were not agreeing about this. Are you interested to attend virtual learning meetings? 74.3% were interested. Which subspecialties don't benefit from virtual learning? Usually, there was no any significant difference in the incidence between the different neurosurgical subspecialties. The third component concerns the future of virtual learning. Do you expect increased virtual learning in the future? In 69.7% of participants could expect increase, they are expecting increase in the virtual learning in the future. Could you pay fee for virtual learning? In 64.1% of participants, they are not accepting or are not willing to pay fees. What are the factors that influence participation in virtual learning? The most important three factors is time flexibility, speakers list, and cost. Could virtual learning alter the neurosurgical education in the future? 62.4% of the participants said yes, it could alter the neurosurgical education in the future. It was possible to do multivariate logistic regression analysis while comparing North America with Sub-Saharan Africa. We found two significant results. Sub-Saharan Africa say that virtual learning will alter the education and training strategies. Sub-Saharan Africa also are willing to pay a fee in order to attend the future virtual learning activities. We published the results of this global survey in the Neurosurgical Focus. Let us go to the second survey, which is an African continental survey. The first case reported in Africa of COVID-19 was in Egypt. It was reported in 14th February 2020. This survey was created by the African Young Neurosurgeons, and as secretary of the Continental Association of African Neurosurgical Societies, I disseminated this survey to all the 5 regions in Africa, North, South, East, West, and Central African regions through the second vice presidents. We had 123 respondents from 23 countries. 113 out of these respondents were under 14 years of age, constituting 91.8%. This map shows the countries which contributed to this survey, which are colored in green color. They show the incidence of contribution of African countries. The maximum contribution was from Nigeria and South Africa. In what clinical area did you suspect that you have been exposed? 35 participants that they were exposed to COVID-19 in the emergency department. What about the impact on training? Respondents, 71 of them said that examination was postponed. In 24, examination was canceled, whereas departmental teaching was canceled in 54 participants, which constitutes 43.9%. Impact on the outcome. Fortunately, there wasn't any effect on the outcome in 104 participants, 84.6%. Impact on clinical activity. The elective surgery were reduced in 91.9%, whereas clinics were canceled in 61% and reduced in 45.5%. Emergency surgery was reduced in 74.8%. We published our results of this continental survey in the World Neurosurgery. This table shows the difference between both surveys. The global survey constituted of 891 respondents, 165 from Africa. The continental survey, 123 respondents from Africa. The global survey was mainly concerned about the impact of COVID-19 during the pandemic and on neurosurgical education during the pandemic and in the future. And it was mainly focusing on the virtual learning, whereas the continental survey was concerned about the impact of COVID-19 on training programs during the pandemic only, not in the future. And we are glad to have some conclusions. Definitely, COVID-19 is turning point in the neurosurgical education. COVID-19 is an actual beginning of virtual learning. Virtual learning will not be an alternative to real meetings. However, it is an alternate method of education which can be used for future crises. Credibility and coordination are very important. Virtual learning is more appropriate for sub-Saharan Africa and for developing countries. The long-term impact of virtual learning on neurosurgical education is still not evident. However, it seems that virtual learning and in-person learning soon will be integrated with each other. And we are going to have another category of meetings, what is going to be called hybrid meetings. As second vice president of the World Federation of Neurosurgical Societies, I organized 30 webinars since the beginning of COVID-19 pandemic in collaboration with the Egyptian Society of Neurological Surgeons and the Continental Association of African Neurosurgical Societies. Our organizations were among the most active ones in arranging these scientific activities. I don't know why Professor Wan didn't mention the series of webinars we are organizing among the last 8 months. This is some of our webinars. Apart from these conclusions, let me tell you my personal opinion. I can tolerate a webinar for 1 or 2 hours. However, complete scientific event for 2 to 3 days will be exhausting. I also believe that social events is an important part of any meeting because it builds and maintains friendship between each other, something which is not available in virtual learning. This table shows simply the difference between virtual learning and in-person learning. The virtual learning, there is little cost or free. They are time saving. They are suitable mainly for sub-Saharan Africa and developing countries. However, it's not considered to be the proper way of developing neurosurgical skills. As new technology is becoming more advanced, for example, virtual reality platforms, operation room live series, augmented reality, and simulation labs might change our concept in the future. I'm also honored to have another publication. This was one of the first surveys done globally about the impact of COVID-19 pandemic on neurosurgeons worldwide. I did this survey with my team and it was published in Neurosurgery. And I'm proud to be one of the authors of this publication, which honors our brothers and sisters, neurosurgeons who lost their lives while fighting against Corona. Let me end my talk by sending my prayers to all of them to rest in peace and to be in heaven. I have 2 important announcements. Webinar number 29 will be an educational symposium of the World Federation of Neurosurgical Societies. It will take place on Friday, 11th December from 2 to 5 p.m. Egypt time. The announcement and registration is already available in the rotating banner in the WFNS website. Another important event will be held on Friday, 18th December from 2 to 5 p.m. This is going to be webinar number 30, promoting neurosurgical research and publications with Professor Nelson Oyasiku, the President-elect of the WFNS of Neurosurgery, editors-in-chief around the table, editors-in-chief of the top journals are gathering in this webinar with the objective in order to improve, to increase the submissions, the rate of submissions of articles to the top journals of neurosurgery, to raise the standards of these articles, and accordingly to increase the incidence of acceptance. Thank you very much.
Thank you, Nasser, for this outstanding, challenging, exciting, and provoking lecture, and your readiness for preparing these webinars. You are very active, and I'm very glad to see that and to hear that, and we can learn a lot from you. Any question, comment for Professor Nasser, Professor Tomasello?
Now, sir, my congratulations for this excellent presentation.
Thank you, my friend.
Demonstrating how long you are doing your job also with the scientific papers. I know very well that you promoted the communication within the neurosurgical community in the African continent and also beyond. I would like to ask you how you see, we know exactly what virtual learning can give residents and which are the drawbacks eventually of the virtual learning. But how can you arrange the practical training? You think that, for example, some app centers can be suitable for practical training if you decide to have simulators, probably which are expensive. They can be organized in some app centers, especially in some African countries. So this is my question: practical training in Africa neurosurgical community.
My friend Tomasello, thank you for this question. I think in the future, with this advanced technology, it will be possible not only to do training, but to do certification. And with the introduction of simulation labs and augmented reality and virtual reality, this will change our concept about the strategy of neurosurgical education in the future. I know such technology is very expensive. It's already available, but in very few centers. But I think if we wait for the future, it's going to be available and it's going to be applicable.
Thank you.
Thank you very much. Any other question, comment? Well, we move on. One important information, my kind request at the end of the meeting, please, I would like to kindly ask all of you to turn on your cameras to make a mutual screenshot of the meeting. And I would like to welcome all forthcoming speakers who are now connected. And I will announce them when the time of the lecture come. Now it's my great pleasure and honor to announce Professor Dr. Kresimir Rotim, my brother from another mother, establisher of Southeast European Neurosurgical Society, and many more entitlements and affiliations he has, as he is as well as second vice president of World Federation for Neurosurgical Society for Southeast Europe. And when I look this outstanding meeting back in let's say more details, I can say that Serbian Neurosurgical Society is real privileged, and we have now a president and the second vice presidents and honorary presidents of World Federation. We have a president of national societies. We have a president of regional societies. We have a president-elect of European Association and appointed presenters of actual president of European Association. So this is, for me, I'm very happy. Thank you very much for this privilege that you all give to the Serbian Neurosurgical Society. And now Professor Kresimir Rotim with his lecture, which is devoted to the impact of COVID-19 pandemic on management and care of patients suffering traumatic brain injury and institutional experience. Please.
Dear Lukas, my friends, dear colleagues, greetings from Zagreb. Zagreb is right now at the peak of the second wave of COVID tsunami. We have at this moment 4,000 new cases per day, and it's still growing. We are not at this moment reached the plateau of epidemic, and unfortunately we have 1,655 deceased so far. So I will tell you a few words about the impact of COVID-19 pandemic on the management and care of patients suffering traumatic brain injury. And before all of that, I would like to share my real gratitude to Professor Lukas Rasulic to organize such an event, to let us all see and hear from our friends from all over the world, because we are all in really unique situation that we didn't see each other and share the experience and friendship and knowledge from the beginning of this year. Special greetings go to, of course, Professor Servadei, Professor Tomasello, Professor Sami, our teachers and leaders. So the COVID-19 pandemic was declared a worldwide public health emergency by WHO on January 30, 2020, and the Croatian neurosurgical facilities have been swiftly reconstructed to better handle the pandemic and to evade possible risk of health system failure. Department of Neurosurgery, my department, and Sisters of Mercy Hospital in Zagreb. At my department, the emergency surgery capability are enforced, insisting on proper mobilization and protection of surgical workforce, trying to minimize the risk of disease transfer through the medical personnel. Elective surgery during the period of pandemic, we performed elective oncological and vascular patients, which were operated on continuously in separate operative theaters, although in lesser numbers. We might say that during the pandemic crisis, we operate, let's say, 50% of regular pre-pandemic program. Surgery of spinal degenerative disease was mainly postponed for a few months, if not being urgent elective. The find out of if the neurosurgical service for traumatic brain injuries follow-up consisted of 95 patients operated on during for 2 months consecutive period. First pre-pandemic period, January 1st until February 29. Second COVID-19 lockdown period, March 1st till April 30th. And third immediate post-lockdown period, May 1st and until June 30th. And the fourth summer post-lockdown period, June 1st till August 31st. So everybody's talking about quarantine today, and I would like to remind us all that the quarantine was first introduced in 1377 in Dubrovnik on Croatian Dalmatian coast, and was the first permanent black hospital lazaretto, which were opened previously in the Republic of Venice on 1423 on the small island of Santa Maria di Nazareth. Let's go back to the distribution of patients during the entire period. We're talking about traumatic brain injury patients in a local area of Zagreb. The distribution patients, accordingly, we have spotted during the lockdown, the post-lockdown period, considerably fewer number of surgical TBI were admitted at the hospital and operated on. The division according to the type of TBI, acute subdural hematoma is the type most frequently observed in 45% of the patients, and the severity of TBI, as you see, the majority of patients are mild, coma score 14 to 15, varied in relation to the period of treatment. The severity of TBI varied in relation to the period of treatment in a way that the incidence of moderately injured patients, coma score 19 to 13, reduced during the lockdown and post-lockdown, that means summertime. Method of surgery, decompressive craniotomy. Craniectomy was the method most frequently used. 60% of the patients had undergone decompressive craniotomy procedure. The sizable majority of surgical TBI patients, 57%, recovered well following the surgery. Post-operatively, all were housed at intensive care unit, and afterwards all were accommodated in appropriate separate wards to minimize cross-infection, and the majority of them recovered well. During a 5-month period from March 22nd to until August 21st, 16 urgent elective and or emergency neurosurgical patients were operated on according to a specifically designed operative protocol, where everyone coming from an outward hospital or institution without having a nasopharyngeal swab test was considered COVID-19 positive. The series consisted of 12 male and 4 female patients, mean aged 65 years. The oldest one was 88 and the youngest one was 20-year-old men. All of them were tested for COVID-19 and none abided a positive result. They were all surgically treated accordingly to the COVID-19 operative neurosurgical protocol due to an emergency prior to receiving the NS test results. All intracranial hemorrhage of various causes was mainly observed, including traumatic acute epidural and subdural hematoma, spontaneous intracerebral hematoma, as well as chronic subdural hematoma or hygroma. All patients underwent decompressive unilateral craniotomy, except 3 patients with chronic subdural hematoma or hygroma where cranial trepanation was carried on. The 2 patients with spontaneous intracerebral hematoma were external ventriculostomy was only performed. We had implementing national public health recommendation and according to specifically designed operative protocol for COVID positive patients, urgent elective and emergency neurosurgical patients, a separate operative theater has been created for the management of high risk or high complexity patients who may have been exposed to COVID-19. Careful clinical prioritizing was assured to select the patients for surgery and to maintain social distancing, enabling medical staff to remain safe and risk-free. The staff was provided with PPE in the operating theater and the NS testing of symptomatic patients scheduled for surgery was complied. However, PCR testing was performed on symptomatic neurosurgical staff only. Since the beginning of the autumn, because it's a seasonal disease or epidemic, second wave of pandemic occurred, hospital system has been burdened by extensively increased number of patients and hospital admissions. And in conclusion, we may say that although the management and patient care was significantly altered during COVID-19 period, including pre-pandemic lockdown and post-lockdown period, the quality and high standards of neurotraumatic care were applied with each and every patient. This was our article on Croatian experience in implementing an operative protocol on urgent elective and emergency neurosurgical patients during the COVID-19 pandemic in WANS neurosurgeon publication in at the beginning of this year, at the middle of this year. And let me introduce you to the next Southeast European Neurosurgical Congress, which will take place in Opatija, which is a very nice city on Croatian coast near the Italy. It would be 5th Congress of Southeast Neurosurgical Society, called Neurosurgery Reviewed. It will take place from 24th until 27th of June of the next year. And let me finish this presentation with some thoughts of Milton Friedman, who said only crisis, actual or perceived, produce real change. When that crisis occurs, the action that are taken depend on the ideas that are lying around. Thank you. I'm finished with my presentation and hope to see you very soon in person.
Thank you.
Lukas?
Thank you. Yes. Thank you, Kesho, for this excellent presentation. Congratulations on your publication of your results in doing neurosurgery in this exceptional circumstances. And we will have time for, let's say, some kind of conclusion at the end of the meeting regarding the fact that we all have a practically similar experience in this, all over the world regarding this situation. Please, any comment, question, or something to the presentation of Professor Rotim. Kresho, you can stop sharing your screen. You can stop sharing your screen.
Okay.
So if there is not, we will have a final remarks at the end of the meeting, just to welcome Dr. Ibrahim Omer Hodzic, also COVID survived neurosurgeon, but ready for action in the future. Now I will continue with the next speaker, another pillar of Southeast European Neurosurgical Society, strong pillar from Romania, second vice president, previous second vice president of World Federation of Neurosurgical Society and president of Romanian Neurosurgical Society, our great friend, Professor Stefan Florian, who always has very challenging titles of his presentation, at least conclusions. Don Quixote de la Mancha Reloaded. Please, Stefan, continue. Stefan, can you hear us? Turn on your microphone, please.
Okay. Now you can hear me?
Yes, you can hear, we can hear you and see your presentation and see you. Everything is fine. Just continue.
Okay. So thank you very much, Lukas, for inviting me for this unique experience in which we are sharing our experience with our daily battle with invisible and unknown. In our quixotic idealism, we are facing with the continuous changing of the reality that leaves us with the sensation that we are fighting with windmills ghosts. So, as Don Quixote de la Mancha mentioned, change the word, friend Sancho. It is neither utopia nor madness. It is justice. So we voluntarily renounce to our liberty in order to escape from invisible evil. And similar to what is happening in the novel Don Quixote de la Mancha, you are never certain that you truly got it, because as soon you think you understand something, Cervantes, and in our case, COVID-19, introduce something that contradicts your premise. The figure of Don Quixote represents the hidden essence of human culture, the centrality of heroic madness and its related death anxiety in all people. I don't have any conflict of interest, and all the cited quotes are from wiki quotes. Let me start to present our local conditions. We are practicing neurosurgery in a more than 100 years old building, built up initially as a psychiatric facility. After 3 remodeling, renovations, now we have 58 ward beds and 16 ICU beds. And in normal condition, we can offer up to 2,500, 2,700 surgeries per year. So our situation was somehow particular because we have to transform an over 100 years old building with lack of functional circuits in a facility with separate COVID-19, because we were forced by the local administration to solve not only the non-COVID cases. The governor placed the responsibility to select the cases toward the local administration and farther toward the head of the surgical departments, and also to solve the COVID patient in a situation in there were no other neurosurgical facilities in COVID hospitals or support COVID hospitals. So in that building, we were forced to reimagine our daily activity, daily practice, in order to cover all the aspects of these daily battles. So we fight with unknown. Like all of us, at the beginning, no one knew what we are fighting with, how severe could be the affected our region, and how we are able to assure neurosurgical treatment. In this situation, we imagine some special precautions, new rules and regulation, new working programs, and new functional and physical circuit. Functional means that in the moment of the transfer of the COVID or suspected COVID patient, no one will interfere with the circuits. So we elaborate 20 pages of organizational measures concerning working program. So we separate the surgeons and the anesthesiologists, all medical personnel. We create separate circuits for medical personnel. We establish and define what is the emergency and what are the criteria for admission. And we learn how to equip and to de-equip during all this practice. So many simulations and sessions of instruction were organized along with banners placed in the points of interest from the receival zone to the operating theater and the COVID compartment. And you can see here, these were the banners in which we tried to learn how to equip, which are the persons involved in the receival team, in the emergency receival zone, in the operating theater, how to equip, how to re-equip, and how to transfer the patient in this small building. So we started from the presumptions that every admitted patient is potentially affected and a possible vector for infection. And for this, we tested every single patient before and at the admission. All the emergency cases were introduced on the special created functional circuit, the so-called COVID circuit, until negative testing was obtained. And you see here the first team, first receival team, and the first operating receival team and me preparing for the first operation on the COVID circuit. So we reorganized the ICU unit and we transformed it into COVID compartment with special dedicated intermediary zone, with equipment, the equipment zone, with strict access to the red zone, with some around 4 to 5 beds, specially dedicated for the COVID positive patient. And similarly, we organized the operating theater and all the activity. So with these new rules and regulation, and with a strict adherence to the new regulation, until August, we had a single affected medical personnel, but with an outside source, with no infection source inside the department and no interruption of the activity. So in this period, we managed to solve as many as possible patients, elected and emergency cases. This was a COVID positive 14 years old girl with a PNAT admitted in emergency. It was difficult to operate in the full equipment for protective, to protect all the member of the operating team for more than 7 hours. And this 11-month child also operated in emergency with a severe head injury produced by a dog bite. Our experience was challenged not only with these quite simple cases like this COVID positive parietal meningioma, but also with ruptured AVM, 57 years old male. We knew this case, we followed it for more than 6 years, but unfortunately, suddenly the rupture produced and we were forced to operate in emergency in a fully equipped on the COVID circuit. So another case with a ruptured pontine cavernoma, also COVID positive. We were forced to admit her and to operate in a COVID situation with full equipment. It was not so easy to handle all the instrumentation in that condition, but we finally succeed through a retrosigmoidian approach, peritrigeminal approach, RIA, to completely remove the cavernoma and with a very good neurological follow-up. So if we look to the distribution, the monthly distribution of the operations, we see that we had a decrease of number at the beginning of the pandemic in our region, but slowly we increased our number of operations, including also the elective patients, at the level which was appropriate to that before the pandemic. So we were able to offer certain neurosurgical treatment for many patients during this period until the mid of October, and we included in every single operation at least 2 residents in order to form that. So our education was not so dramatically decreased in this period because we were able to train them, and in every operation were at least 1 senior resident and another younger in order to develop their surgical skills and to learn more and more. So we were very occupied to include at least every single resident at least for 3 to 4 times per week in the operating theater. The favorable aspect of this COVID, as it was mentioned previously, was that the number of the trauma cases decreased, especially the spinal trauma cases, but also the traumatic brain injuries in this period. And if we compare our activity from this year to the previous year, to the 2019, we can see that we have a decrease of around 400 operations for the first 10 months of the year. And this decreased number of the operations was mainly because of the decreased number of trauma cases and also of the decrease of the degenerative spine cases. We were selected them rigorously. But if we look to the, excuse me, I will go back a little bit because it's important. We had a little slightly higher number of the brain tumors operated in this year than compared with the previous, and also a significant number, higher number of the cerebrovascular pathology, the aneurysmal surgery, the AVM surgery than the 2019. But as I mentioned, the number of the chronic spinal disease has significantly decreased in this year. So until the mid-October, the things were as I presented. But suddenly, because of the accumulation of some general condition and also some departmental condition, and when I say general condition, I refer to the second pandemic wave, to the reopening of the schools and certainly local elections we had in September. And also we had an infected asymptomatic medical personnel outside from an outside source and a false negative patient. And these two persons dramatically produced an explosion of the cases in our department. So in less than 10 days, we had 28 infected patients. 4 of the patients died because of the multi-organ failure. Most of the patients with a good neurological condition were transferred to the support COVID hospital. And we also had 45 infections among the medical personnel that represent 21% out of 212 employees. So fortunately, none of them were hospitalized, majority with minor and medium forms of disease. But this produced a dramatic decrease of the number of operations in November. You can see here only 56 compared with October, in which we had almost 200. So we completely stopped the activity for 1 week. Only major emergency from Cluj country were operated. We made a final disinfection of all spaces and kept the minimal necessary personnel. And also we introduced new additional rules and regulation. We split the entire surgical team in 4 groups, in 4 teams, and we were permanent wearing of intermediate risk protection equipment during the entire day. So we reduced the number of the beds to 220, and we increased the number of beds for COVID compartment from 7 to 11. So all the admitted patients should have 2 negative COVID testing at 48, 72 hours interval at least. This is a new regulation. And with these new measures, new regulations, we now don't have any new infected case in the last 2 weeks among the medical personnel. So this is the today's situation in our department. So I will end with some other quotes from Don Quixote de la Mancha. Tomorrow will be a new day. Honesty is the best policy. I will stick to that. Diligence is the mother of good fortune. Fortune leaves always some door open to come at a remedy. Every man for himself and God for us all. And the Cervantes had a great premonition regarding these webinars we are organizing now. He mentioned that journey over all the universe in a map without the expense of fatigue, of traveling, without suffering the inconvenience of heat, cold, hunger, and thirst. Thank you very much for your attention. Thank you, Lukas. And I would like to take the opportunity to thank to Kresimir and to Professor Sami for the contribution to this new released book. Just it was published last week, Pineal Regional Lesions, a small region with huge pathology. Keep safe, and I hope to see you all as soon as possible. Thank you.
Thank you, Stefan, for this, as usual, excellent presentation and challenging for all of us. Always following with a perfect quotation, which challenge associations of for many things, good things. Any comment, question to the related to the presentation of Professor Florian?
Yes, I have a comment on Florian. First of all, Florian, thank you very much. Very honest presentations. Very frequently when we have these webinars, we lack reality. We do surveys and things like this, but you have shown in reality what you were doing. We had the same experience as you, exactly the same. In the first, well, not, the first period with us was much worse as you, not like you, but we didn't have as many infected personnel. The infected personnel source is coming from outside. So it's in the second wave because they say, for instance, that opening school is easy. We don't get infection, everybody is, well, in my department, all the four of us who had a wife who was a teacher were all infected. So you can understand that the schools are important for all of us, but they are a source of infection. There is nothing we can say. So we got a lot of infections in the hospital from outside, which didn't happen in the first time period where we had the lockdown completely. So I just wanted to ask you, you are showing now that you repeat 2 tests within 3 days. What we do is doing a test within 72 hours. And on arrival, we do a chest CT scan because, you know, the chest CT scan has high specificity for small pulmonary lesions. We sometimes are coming earlier than a positive test. Which is your experience, Florian?
So for sure, we are checking all the patients. So firstly, when we are programming and we are accepting a patient, we are asking for to have a negative COVID test before the admission with at least 2 or 3 days. At the admission, we are performing another in our genetic center, just in front of our department. So we have 2 testing, and for every single patient, we perform a CT, thoracic CT, in order to have a complete picture of the patient.
Thank you, Stefan. Please stop sharing your screen.
I tried, but I
stop sharing your screen because
okay.
yes, now it's okay. Now it's okay. Now it's perfect. Any other comment on related to the presentation of Professor Florian?
Can I just a question to Stefan? Stefan is
Yes.
I'm very glad to see you healthy.
I miss you.
And many compliments for your presentation, and also for your book is very nice. But I wonder, I have just a question. How do you decide which, in case of a positive patients, when to postpone surgery or when is really urgent surgery? Did you perform a grading system for what is postponable or what is urgent or not?
So we are all here, the senior neurosurgeon, we are experienced. We perform a team to decide concerning the brain pathology. We have a team, and for the spine surgery, we have a different team with a spine surgeon. So in cases of emergency, we admit the cases discussing all together, which is how to prioritize the case. But sincerely, we didn't stop really the cases with COVID positive if they need a surgery. We took all the precautions in order to offer the treatment, and as soon as possible we treat it. We send it to a hospital, COVID support hospital, in order to be treated. So, you know, from your experience, which patient could wait a little bit, 2, 3, 4 weeks, and who should receive immediately the treatment?
So I would say in this optic, you didn't really modify your...
Not really. Okay. We are discussing.
Very interesting.
We are deciding, because if you impose some protocols, rigid protocols, you may lose some patients. So we are flexible and we are thinking about every single case.
Thank you.
Thank you for this nice discussion. If there is not any more comments or questions, we can move on. Our next speaker is our very close friend, another pillar of Southeast European Neurosurgical Society, chairman of the Southeast European Neurosurgical Society chapter in North America and Canada, and second vice president of World Federation, as well as chair of International Neurosurgical Program of American Association of Neurosurgical Societies, originally from Sarajevo, from Bosnia. So my pleasure to introduce Professor Kenan Arnautovic, who will give us a lecture related to the COVID-19 pandemics in North America, experience in survival and practicing neurosurgery from Samus Murphy Clinic and Department for Neurosurgery, University of Memphis in Tennessee, United States. Please, Kenan.
Good morning, Lukas. Good morning, dear friends and colleagues. Good morning, our teachers and professors. I'm very happy this morning at 6:05 local time to present my presentation, and we are really happy to be together, at least with this opportunity online, to see each other faces on the screen rather than be in person. But I hope we will have opportunity to do so in the near future. I'm going to present my experiences, or our experiences, better to say, in my hometown in Memphis, which we struggled through this pandemic, as all of you did, with all the ups and downs, with all challenges we have, and we are still facing it. So I don't have any disclosures, commercial disclosures in my presentation. As many of you who has from this screen visited us as visiting professors, and I hope eventually all of you will come and visit. I currently live and work in southwest corner of state of Tennessee. You can see here it's tri-state area between Tennessee, Arkansas, and Mississippi. This city is called City of Three Kings. Martin Luther King, Elvis the King, and B.B. King. And it's hotbed of music and entertainment, as well as sports. Many of the famous actors and musicians were our patients or my patients over the years. And we are honored and privileged to be practicing in this great city. Our university, you know, everybody says, oh, United States, everything is very, very young, you know, they don't have traditions. So our university is only 226 years old, and our School of Medicine is only 170 years old. And this is a picture of our clinic within our system. We are one of the oldest departments of neurosurgery in the world. Everybody's talking about Cushing and Dendy, but this gentleman in this picture, Professor Sams, and his successor, Professor Murphy, the clinic is named after them, are among the third and fourth neurosurgeons in the world. And they came to this city 108 years ago and established one of the first neurosurgical department, which is still alive and doing very well. Our department has given 8 out of 87 president of American Association of Neurosurgery. And we are proud of this leadership throughout the years. This is our current roster of my partners who practice neurosurgery with me in our 10 hospitals. And back to the subject, as we all know, we were hit hard with this virus exactly a year ago now, a short 1 day or so. We were all, as Professor Florian said, we were all faced with a very, very challenging situation where we didn't know what to do, how to fight the unknown, unseen enemy. And we all struggled at the beginning, but pretty quickly caught up with the challenge, and were able to deliver the care to our patients. But most importantly, we were able, at least in our community, but I can see everywhere in the world, talking to my friends and brothers, neurosurgical brothers throughout the world, we were able to be the leaders and to show all the specialties how to handle this crisis, along with other great colleagues, not to minimize their contributions and their part in this fight, which is enormous. So as you all know, this is just data from a few days ago. The number of cases is still enormous. The number of deaths is still enormous. As you all know, my country, United States, is one of the leading countries, unfortunately, leading countries with number of cases in the world. And these are just some data taken off the internet. And when we look into the United States, you can see here how the country has been hit hard tremendously, especially eastern part of the country, but also West Coast. This western part of the country is not populated as much, but it is still hit hard, as you can see here. And especially, you know, the big cities were hit hard, but also communities in between the big cities. And you can see here the curve is still rising. As far as Tennessee is concerned, we are number 9 on the overall count. And you can see here, unfortunately, the number of cases are still rising. So what I just did for the sake of this presentation and just for other quality improvement performance, I wanted just to illustrate to you that in the worst crisis, in the worst situation, leadership means most. And we have to do one and everybody. We need to pull together, and paying, as Professor Florian and others have shown, perfing the best quality performance outcomes is the way out, is the way to minimize the risk of infection, is the way to improve the quality of our patients, because our patients demand not less than perfect outcome, even in the full gear equipment of ours while performing the most difficult surgeries, even in the pressures, psychological, physical pressures, recovering of COVIDs, many of us, etc. So we have to do the same we are doing now, and even more than we are doing in our routine, quality and performance. As our Latin ancestors will say, navigare necessa est, vivere non necessa est. So we all had in April hospital lockdown where we didn't do electives, but then we realized we have to leave navigare necessa est, and our hospital quickly separated COVID floors and ICU, COVID ICU from the rest of the hospital. All neurosurgery patients were tested before elective surgery 3 to 4 days, and then they quarantine until surgery. We did go as far to test routinely with CT chest. This is a new, we may need to discuss this, but this is a new to me, that screening was done with CT scanning of the chest. All emergency, even if some patients come with non-emergency case like a brain bleed that may potentially become operative, we give them a rapid test in the emergency room just in case they worsen, that they need surgery, so they are ready. And of course, COVID positive patients have surgery in bubble OR, which is a special OR that was constructed with negative pressure to perform. All patients coming to the clinic for preoperative, postoperative visits wear masks, and all doctors, nurses, and all personnel wear masks as well as protective gears all the time. We adopted this at the very, very early onset, and so far among 25 or 30 partners that we have, we only have 3 people who were infected. Thankfully, everybody did very well. And the other thing I want to mention, we all established very early online visits for our patients. And what I could see, the specialties around the state of Tennessee flourish with this online visits, but not neurosurgery. Patients, our patients with brain tumors, with spinal tumors, with vascular anomalies and all other pathologies, degenerative spine, want to come in person despite COVID and see the neurosurgeon. This is a very interesting phenomenon, at least in our experience, that we need to look into in the future. As experience from other places, we did almost the same number of cases year to date. These are just, you see, these are our, I don't know exact number, but 12, 13 hospitals that we service in our area, in our city, Memphis metro area. And the number of cases is almost identical as last year's. This is in my hospital where I'm chairman, the biggest hospital in Memphis. The number of cases of physicians that performed over this month. And this is only one hospital. We also operate in other hospitals. And we pay very close attention. These are 2020 cases. We do look into length of stay. We do look into mortality. We do look into readmission rate, complications. We do look into cost of the case even. And you can see a lot of greens meaning perfect. These are the outcomes compared to the national database, very exact parameters. And these are not the parameters that we perform. These are parameters the special service in the hospital performs. We are just, the only thing that we are not doing exceptionally, that we are not leading in outcomes in our United States, is the cost of the case. We have to work a little bit on this, how much money we spend on each case. As you see, this time of quality, be it in the pandemics or outside of pandemic, came to us 10 years ago. I know some places do this, some places don't do, but this is our future, guys. And if we don't embrace it, they'll embrace us. We look into block time utilization. All of us have certain days in the week when we operate, and they look how we operate. and how often we use this time. And hospital says if you don't use it every time you have it, they put you on the red flag. We look into OR delays when if the case is 7:30, you have to start at 7:30. The pandemic doesn't matter. And you can see here, these are data up to September, how we start cases on time also, and we strictly enforce it. Stroke appropriate care score, you know, they're all parameters on the stroke care, and we also monitor them as well. Craniotomy, you can see, you know, and this is one of the prides, you know, where I'm leading neurosurgery in this particular, for example, hospital, that even in the worst pandemic, the infection rate is extremely low. Same is true for VP shunts. Same is true for fusions, for spinal fusions. And again, these are not things that we do ourselves. This is data from the hospital. And this is not something that we are bragging about. I'm just trying to be a little bit proud and see, you know, how we can perform well even this most difficult times. Severity adjusted mortality rate. And also I want to illustrate to everybody how painstakingly precise we are continuing to do monitoring of quality even in the worst of times. Mortality rate also is here, stroke severity adjusted mortality rate. I'll just go quickly through the list just to illustrate what we are monitoring. Death in low mortality drugs, diagnosis, death in patients with treatable complications. So if patient has after surgery complication, you treat it and the patient succumbs, that's the graph. Readmission rate, so this is 30 days readmission rate. You know, in the United States, and I'm sure in your places, they strictly monitor how many cases Dr. Arnautovic operates a month and how many cases come back within 30 days with complications to the OR and how many cases each, and then they compare you with all the other partners. So it's kind of pretty nervous to see the graph at the end of the month and see how you fare with the rest of your, you know, the time of our claiming that we don't have complications, the time of us claiming that we do perfect neurosurgery is over, at least in place where I practice. Every month we have a screen, even in the pandemic, and we know exactly how did we fare. Again, readmission rate excellent, as you can see here. Stroke is a little worse than routine elective cases. Postoperative hemorrhage or hematoma, results of returning to the OR. You can see here 2 cases in May and June, and 0 cases July, August, September. Postoperative respiratory failure. These are the cases that require reintubation after being re-extubated. Postoperative pulmonary embolus or deep venous thrombosis. Dural tears, these are non-intended dural tears, especially in the spinal surgeries. Again, you can see here the outcomes. And this is, you know, I don't know in your places, but in our place, in our country, every patients or a good number of selected patients after they are discharged from the hospital get a survey. And in the survey, they ask them about 5 or 10 questions about your doctor, your hospital, and your outcomes. And these come back and they are cured by a physician provider. They are cured by diagnosis and by all different statistical analysis. And one of the questions is, how often did the doctors treat you with courtesy and respect? Okay, and you have no influence, and you don't even know who answers and who didn't answer, and then hospital shows you what's your scorecard. How often did patient listen to you carefully? How often did the doctor explain things in a way that you could understand? And you see, these are, some of these numbers are great. You can see this one and this one. Some of these numbers, we still need to do a little bit of improvement. How often did the doctor explain things in a way you could understand? And then, so this is really, really something sobering to me in the last 10 years. And you know, don't be scared of this. This is coming your way. If it's not, you just learn to live with this. You just adopt. And we are all people who practice neurosurgery for many decades. We have all more or less excellent results. So this is not something terrible that will, but it's very interesting to see how you perform, how your clinic department performs among other departments in the state and country, and in the world where it's available. Length of stay, you know, how many patients after your brain, how many days your patients after your brain tumor stays in the hospitals, and how do you compare with your peers in the hospital and in the nation and internationally. Arithmetic length of stay and so forth. So, so what we, as you all did not, education of residents and fellows was undisturbed. Our residents and our fellows are participating from day one in our cases. They are taking part of taking calls with us. I'm on call this weekend for the hospital, and I have my 2 chief residents, other residents. And you know, in the United States, our residents and chief residents perform surgeries under our guidance many times or most of the times, and we assist them. And of course, they perform surgeries where they are qualified to perform and up to their level, and we interject in the surgery as much as needed and as much as is appropriate. So it is in-flight training, and I know in your countries also, but professors here are many times assistants and providing the education on your pay, because also our residents evaluate us and tell the world and our national societies how good teacher is Dr. Arnautovic, Professor Arnautovic, how much he teaches, how much he allows residents to operate, how much he gets them involved in preoperative and preparations, postoperative care. Weekly departmental meetings, we turn online like everybody else. And this is also another experience that we have learned. Publications record high. I can see everybody publishes like crazy. Probably people have more time since they don't travel. And then we all have almost every weekend some online meeting. Professor Gandour has shown a great organization that they do, and everybody else. And this is something new that we have also participated in. And I don't know what future brings. I think it's completely different psychological things to do online meetings rather than hybrid or in person. And you know, it's somebody mentioned earlier, you know, being 1 or 2 hours with this online meeting is okay, but being 3 days is very exhausting, as opposed when you travel and go in person, it's different because you in person you have other way of refreshing your mind and your activity. We also maintain every month morbidity and mortality conference. You know, this is the conference where residents, not you, residents prepare all your mortality and morbidity, and all the department, 25 neurosurgeons meet, and they put together pictures of your preoperative and postoperative cases. And this is something that you cannot influence. You just sit there and then answer the questions of your peers. Why did you do something? Why didn't you do that? It's sometimes a sobering experience. Just a few words about protective equipment. As all of you, we use N95 masks, and I personally adopted usage of N95 masks. The moment I get out from my home in the morning to the moment I come back, I don't take it off. The only time I take it off is in my office. If I am having lunch, my sandwich, I will take my protective equipment off after disinfection process. And I had 3 direct COVID exposures. My nurse, who is with me 24/7, she had infection. Her husband almost died. We were in contact day and night all the time. My medical assistant had the COVID, very hard one. And she also was exposed to me every day in the clinic. And then my eye surgeon, I had a minor eye procedure, and my friend who operates with me on orbital tumors, cranioorbital skull-based tumors, did this minor procedure on my eye. And then after removing the sutures, he called me 2 days later and he said he was exposed. I was thankfully again wearing the mask. So far I dodged the bullet. I don't know what's tomorrow coming, but I think rigorous wearing N95 masks, including glasses and eye shields, is one of the most important things to protect ourselves, at least from my experience. And I have a very, very significant exposure to 3 people who were face to face with me for many, many hours over the course of their incubation. We know about these face shields and visors, which we all use, and then full protective equipment if we have infected patient. We have in the United States of America, we have 3 vaccines that are just about to come. I understand that the planes are still already flying around the country distributing vaccines. And on the 10th of December, I believe, or 7th of December, there will be emergency meeting of FDA, Food and Drug Administration of the United States. But they want to have these vaccines ready in position. And the first responders will be doctors and nurses and hospital personnel. Pfizer vaccine is 95% effective. They say the problem is it has to be stored at minus 95 degrees Fahrenheit, which is a little bit problematic from the handling procedure. And then Moderna vaccine, this is from New York, New York, Pfizer. Moderna is from Cambridge, Massachusetts. It is stable at almost normal temperatures. And again, it's about 95% effective. And then there is vaccine from Johnson & Johnson from New Brunswick, New Jersey, which is just finishing stage 3 trial. As you know, there are 3 trials of vaccines. And we all are hoping and praying that this vaccine will start a slow breakage in this nightmare. At the end, I would like to quote one of my favorite people, Charlie Chaplin, that 6 of the best doctors in the world are sun, rest, exercise, diet, self-respect, and hobbies, friends, and laughter. I thank Dr. Lukas Rasulic very much for his kind invitation, and I'll be very happy to answer if you have any questions.
Thank you, Kenan, for this excellent presentation, like always, and the presentation is open for discussion or comments. Kenan, I believe that everybody are very clear with your presentation, and thank you once again for this. Please stay together a little more, and then we will finish this, I would say, extraordinary meeting for the COVID. And now I will invite another pillar of Southeast European Neurosurgical Society, who are COVID survivor, as I like to say. This is he had a contact with the COVID and they have a COVID infections by personal experience with that. And then he's president of Association of Neurosurgeons in Bosnia and Herzegovina. Our dear friend Ibrahim Omer Hodzic, he will now present us. Neurosurgeons in Bosnia and Herzegovina are among leading medical professionals suffering from COVID-19. Why is that? Please tell us, Ibrahim.
Dear friends, dear colleagues, Lukas, thank you for inviting me. I'm honored to be the part of this nice meeting. So I would like to share our experience with the COVID crisis here in Bosnia, how it's happened. That was actually pretty stable, almost 6 months, and then the situation started to worse. So as I see or hear all the good friends, my colleagues, teachers, and so we shared the almost same problems with the COVID. What's happened in the last 2 months, that situation worsening in Bosnia in the neurosurgical departments. So that was the idea when Lukas called me to share this experience with you, to solve the problem, what's happened actually with the situation with us. So almost at the beginning of the COVID crisis here in Southeast Europe and Bosnia, also between the March and May this year, we was worried that the similar scenario to the Spanish flu will happen, and then after when the 50 or even 100 million people death. But the situation was terrible for 6 months, as I said before, and then we relaxed ourselves a little bit, probably too much, and we didn't follow the recommendations completely, I could say, but also our patients are relaxed too much. So then we had many infected patients who came to our outpatient clinics. So today's situation in Bosnia, which has the 3.5 million population, we had approximately 2.5 thousand deaths. How we started actually in March, we arranged some recommendation for the first lockdown, and we stopped it with the elective surgeries. We asked for PCR COVID tests for emergencies, and we maximized the telemedicine, also consultations in the hospital and also between the hospital and general practitioners. They call us by the phone, on internet, online conference, and so. And then we reduced the unnecessary communication at the department. We changed the regular working time between us. We stopped the usual morning runs and meetings. So we rearranged the working procedure schedule and the usual things at our department. And result was that no neurosurgeons with COVID-19 we found in the first 6 months of COVID crisis in the Bosnia. But what was the obvious, and we was the sad of to say that we actually reduced the number of surgeries for 50% almost. It was visible. I don't know. To be honest, I think that the rules was too strong at the beginning, and also maybe we postponed some surgeries we could doing during that time, but we have been, let me say, serious with following the recommendations and keep ourselves and our patients away from the COVID situation and sources for the infections. And we actually had some kind of the guidances, and we shared the indications. We arranged them in the 4 levels, actually 3, but one was the first one was the emergency and urgent patient, which have to be operated in the first 24 or 72 hours respectively, and then the priority level S2 was the patient who should be operated in the first month, and the last level was the patient which can wait more than 3 months. So in the first priority 11A, 1A emergencies, we operate severe TBI injuries, unstable patients, then traumatic spinal injuries, which are unstable, then intracranial hemorrhage, aneurysm, AVM, and some strokes, hemorrhagic stroke, which cannot wait, and also intracranial hemorrhage, which are not responding for conservative treatment. Then we operated the rhizotite CP cases, cauda equina cases, real cauda equina, and then acute spinal cord compression, and of course the pediatric cases. Then we had the priority 11-1B, which can wait for up to 72 hours. For those patients, we perform usually all the PCRs tests, even the serology, and sometimes CT scans of chest if we need it, and we repeat it again in 1 or 2 days if we need it. And that urgent cases, we counted not responding TBI patient to conservative treatment. Intracranial hemorrhage, we cannot waiting too much. Acute ricid ICP, hydrocephalus, also some spinal cord compression, baclofen pumps failing, and pediatric cases which cannot wait more. Then we had level 2 patient who could wait for a few weeks, including the tumor surgery, spinal tumor surgery, acute chronic pain syndromes like trigeminal neuralgia, and some non-urgent pediatric cases. And those patients who have to wait they were the degenerative spinal disease. We almost stopped it with the spinal surgeries, except the emergencies. Then some epilepsy surgeries, NPH, slow-growing brain tumors, including the meningiomas and pituitary microadenomas, and so. And some patients we sent to the radiosurgery, LINAC, and so. And we saw for the 6 months that situation is stable also in Europe, and there is no any neurosurgeon in Bosnia being infected by COVID. So after the 6 months, after we saw that we have the less than 50% of usual number of surgeries per month, we started with the elective cases. Probably we opened it too early. Our service, we opened the outpatient clinic for all the cases, including control examinations, those patients who are not need actually the neurosurgical examination, almost not at all, but let me say it's not emergency, it's not urgent, it can't wait, we can wait for 4 months. And also we started with the live intra-hospital checkout, including neuroemergencies. We actually opened the hospital almost to the more than 90% of the normal situation, usual situation we do. And what happened at the end of the October, we have the situation that Bosnia and also surgical departments in hospitals started to grow up very fast, especially at the end of the October and the beginning of the November this year. And as you saw, when I saw this first time, the CT of my colleague, like in these blue areas, which is actually CT confirmation of COVID pneumonia, I was worried. I would say, yeah, this is really dangerous, but hope we have all the arrangement in our department, it will not happen to us. 2 weeks later, we started with the first neurosurgeon in the second half of the October. And after the only 20 days after we opened it, the neurosurgical departments for all the cases, we had 34% of neurosurgeons experiencing COVID, including the pneumonia, heart cases. So every third neurosurgeon in Bosnia experienced COVID. Very difficult, some of them. So younger guys, few residents experience, let me say, not so difficult cases. But those who get the pneumonias, there is 1/2 of those neurosurgeons have some kind of, let me say, life dangerous situation. This is my CT performed 20 days ago when I had the pneumonia with those areas which are with COVID-19, including the parts, and that was the dangerous period for us in Bosnia. So we in two hospitals, almost in one hospital, almost all neurosurgeons experience disease. In my department, 1/3 of us has the problem, and then we reduce again the elective cases and non-emergencies. We stop with that. We again started to follow the rules and recommendations we had at the beginning of the year. That was, for example, the routine neurosurgeons checked by neurosurgical cases should be checked by primary care service, and they call us if they have any dilemmas. And we organize two separate department sections. We had it all the time, but not use it perfectly, let me say. And then hospitals should be divided between COVID and non-COVID buildings, not only the wards. It's not worked good. So also the nurses and staff should be divided. And some cases, yes, have to be operated, but all the patients scheduled for the surgery have to have at least fast COVID emergencies, fast COVID tests, and PCR. And then additional recommendations we approved last month is that we screen all the fresh patients with PCR COVID tests, including those who are coming to our outpatient clinic for routine checkout. Also, we postpone elective surgeries, especially spine cases, and we use the protective clothing for all suspicious cases, and we reduce the number of persons who doing the surgery. For example, if I do the surgery, I don't need the assistant in more cases, so there is no need for assistant. There is no need for the additional anesthesiologist, nurse, and so. And what we learned also is from our mistake, if we did mistake, I don't know, that we have to testing ourselves every few weeks, like neurosurgeons for routine testing, as they do it in some countries, in some factories. For example, Ferrari factory in Italy, testing every 15 days all the staff, all the employers, and so we have to be extra careful during the first emergency neurosurgery patient examination in an emergency department, especially if they are breathing with the tube and they are not put it on the machine, because through the tube we're getting the more dangerous air and particles with the COVID virus. So I did this mistake, probably was my mistake when I get the COVID, because the patient was comatose, intubated with Glasgow coma score 4. I want to see it with my resident, so I was there. I just checked it, is he's breathing or not? And then despite my mask and all these things, which are not actually full equipment for the surgery with COVID patient, I probably get the virus. So the first contact with the patients, we don't know who is, if he's intubated, we have to be much more than careful. And also we have to separate area in the hospital, especially intensive care unit, with those patients are treated a bit more than usually. And at the end, I want to say that the COVID is not harmless disease. COVID is not happening to somebody there, but to neurosurgeons also. Keep in mind that some surgeries can be postponed, and we have to wait with some surgeries, not push them to do OR if not necessary. We should waiting the vaccine probably, and the crisis stop, and we are never careful enough. We are never protected enough. Thank you, everybody.
Thank you, Ibrahim, for your excellent presentation. I'm sorry that you have a personal experience with COVID, but this can also be useful for all of us to see how it can be overwhelmed in the future. Please stop sharing your screen.
Yes.
Stop your sharing your screen. Yeah.
Immediately, I will.
Yes. And presentation is open for discussion and for comments.
Can I make a comment and ask a question?
Of course. Please.
So Ibrahim,
Yeah.
I'm proud of you. I'm proud, I know you as a resident. I know you now as a professor and leader of neurosurgery in Bosnia. I'm proud what you have accomplished and seeing you grow over the past year. So I really want to publicly express this notion about your professional and leadership growth in as a president of Bosnian Association of Neurosurgery, and also one of the pillars, as Lukas said, of Southeast European Neurosurgical Society. So kudos to beautiful presentation. Kudos to the great work you do. My question is, I know that everybody has different problems and everybody is struggling with this pandemic. You had one of the worst experiences. I know it personally. I was worried about you. We were contacting almost every day. And I know that you went through a very, very difficult situation. My question to you, did you know the moment that you may potentially be exposed? I mean, we all know we are exposed and it can happen any day. But did you know, okay, I think I got it from patient X, or it's unclear? And then if you can take us briefly, one minute, through the course and your psychological process in your head as a physician, as a neurosurgeon, as a father of 3 young kids and all that. So I would like to hear from you. So do you know how you got infected, or in retrospect, do you know? And then to briefly take us through this ordeal, enormous ordeal you were through. Thank you.
Thank you, Kenan. Thank you for your comments and question. Of course, yes, I could briefly tell you a few words about that. So I think so. That was the situation in the emergency room, and when my resident and my young anesthesiologist referred me that there is the patient who is not breathing, or maybe breathing a little bit, and it's intubated, and then it's Glasgow coma score 4, and there is the subdural hematoma acute, but there is something on the problem with the temperature, and I want to check the patient before I decide to operate or not, because it's not situation for the resident, of course. So I was, let me say, too much comfortable, and I disconnected the intubated patient from the machine to be sure is it breathing or not by myself, So that was the probably moment that I get the virus. And then when I saw that there is something that they referred me that there is the temperature or something, I sent the patient. I asked for the CT of pulmonary of the chest, and then we sent the patient. It was actually breathing alone, and so we operated this patient. Me personally, I asked the senior resident to go outside from the operating room, so I did the surgery by myself to protect the young guys. However, I get all the clothes later on, but I think that this moment, few minutes in the emergency department, was the terrible situation when I was not prepared myself.
Were you protected? Were you protected at that time in the emergency department?
Yes. When they told me during the examination the patient had a high temperature and maybe had something with some contacts with the COVID patient earlier in the emergency department, they have few patients, and one before him came there was confirmed with the fast test. Then I ordered all the necessary, rules, but it was too late probably. And concerning those period when I was sick, let me say, it was the cold for 7 days, temperature, weakness, everything, but it was the, let me say, survivable. But 7th or 8th day after the symptoms beginning, I had worsening. I almost has some kind of paraparesis in the leg, and I cannot stand up on my legs. I had the pain everywhere. I cannot talk more than 3 words. So I visited my infectiologist again. Then we performed the CT. It was positive, and they started with the additional antiviral drugs and dexamethasones, and because of cytokines crisis, and so all the time I get the antiplatelets and so therapy. However, after the 10 days, the situation was even the worse. So, to be honest, I started to talk that I'm going away from this world. So it was for 50 days, let me say, difficult situation that it started day by day coming better. But let me say that for a few days, I thought I will die.
You know, one of the things that I'm amazed, and I know you very well, I know that you are practicing sportsman, that you are very healthy, very active, that you don't smoke, you don't have any, you don't drink, you don't have any diseases, and it's amazing that, you know, and you are young. I mean, you are 40 years old or so. I don't know exactly how much, but what I'm saying is, really, when you see how sick you were, and thank God that everything is great, you know, makes everybody worry. You know, if young, healthy, athletic person without any secondary diseases, without any other risk factors was sick, how us older people and some people with diseases would fare. So that's kind of worrisome.
I think that's why I put at the end of my presentation few recommendations. You are never young enough, you are never healthy enough for the COVID. That I could confirm that, because I don't smoking, I'm swimming, running, no additional mobility. I have the mask all the time, using this disinfection. I checked my younger colleagues, are they following the rules for COVID and so, and I get it. So never safe enough, I think so.
Thank you, gentlemen, for this honest and on the first place, very useful discussion. Now we have to move on. Our next presenter is Professor Tit Mattisen from Acta Neurochirurgica. He is editor-in-chief of Acta Neurochirurgica and as well as member of ENS board. Our next speakers, Professor Tit Mattisen and Professor Fontanella, have been proposed by the president of the European Association of Neurosurgical Societies, Professor Klaus Schaller, to take a part in this meeting. So thank you, Tit, for your patience, and then thank you for accepting this presentation. Please continue with your presentation.
Thank you very much, Lukas, for the honorable invitation and for the initiative to organize this interesting and I think for all of us very relevant meeting. And I can see that very elegantly we are moving from Central European time to GMT, and under this perspective, I think we are actually a couple of minutes ahead of time, which is very comforting. I would like to bring in a different perspective, and this is a perspective of looking at resource allocation. We have studied these topics a little bit, and we published a brief snapshot of European neurosurgery a couple of months ago. We used a questionnaire to try to see how European neurosurgeons adapted to the pandemic. And we were struck by a couple of observations. I believe that the testimonies that we have heard so far today are also what we saw: the postponed elective cases, the sometimes limitation of indications, the reorganized regional care. But I have put a little picture of a school of fish on the right side just to indicate that what we saw is how rapidly and how independently all our colleagues adapted with more or less very similar measures. And all of this adaptation was, in my view, almost like a school of fish using their already existing knowledge of medicine, epidemics, infectious disease to deal as rationally as possible with the new situation. And all of this adaptation was really done days and weeks before the authority regulations and guidelines started appearing. So we thought that the adaptation was done through our colleagues' expertise, and that we saw the guidelines and authority regulations more as confirmatory. Of course, the other observation was that before pandemics, almost all our colleagues considered that they provided care according to all legitimate medical needs. There was only one exception, and that was 2 Swedish centers. While during the epidemics or pandemics, 80% were no longer able to provide care according to legitimate medical needs. And this brings in another topic that I would like to comment. Since 80% were no longer able to provide this care, we end up in a situation where we were no longer able to save lives the way we used to. Actually, the extreme formulation of choosing who will live and who will die became real for many of us. It's well known from medical literature that not being able to treat according to our training, knowledge, and experience may cause moral distress. And there is a thing with this moral distress and how to cope with moral distress. I think many of us just went on to make all decisions, followed the guidelines we had, and we followed best available medical evidence. We keep doing our medical work. We treat one patient after the other, no questions asked. It's all just medicine. But it is not that simple when it comes to resource allocation under shortage. I'm going to repeat a few times during my brief presentation that there is a need to act as responsible moral agents. And I would like to remind you of the concept of banality of evil. This is a concept that was first described by the philosopher Hannah Arendt. She covered the Eichmann trial in Jerusalem in the early 1960s. And what she described as the banality of evil was that she described Eichmann as a person who relied on cliché defenses rather than thinking for himself, and was motivated by professional promotion rather than ideology. So there is a risk of becoming an instrument of making evil moral decisions if we do not realize and take our responsibility as moral agents for making the value judgments and normative decisions that affect others' lives and death. Now, the medical decisions regarding resource allocation are decisions of who gets treated, and these decisions are frequently handled as medical decisions. Now, there is a risk that normative decisions are concealed and perceived as falling within the realm of medical judgment. And the value judgments and moral agency are hidden to offer a false sense of medical judgments. So I'll give a couple of examples of this. One of the major pitfalls is that value judgments are hidden, and value judgments may allow rationing of care under the disguise of triage and prioritization. So please remember the different terms. They are used a lot to describe resource allocation during the pandemics. The word prioritization, triage, and rationing. I'll continue to prioritization. If you look in Webster's dictionary, prioritization is defined as the activity that arranges items or activities in order of importance relative to each other. But when we use it in medical resource allocation, it certainly implies that all legitimate activities can still be done. It implies that resources are sufficient if distributed in the right order. For example, you may have two patients, one with an epidural hematoma, another one with an appendicitis. And of course, you operate the epidural hematoma with threatening uncal herniation before the appendectomy, but you do both patients will be fine. So prioritization as such just implies that you have to use the right order of doing things, and every medical need will be met. Triage is another little bit treacherous word. Triage actually describes a situation where different patients have different needs, and patients are triaged so that every patient is allocated the appropriate management. You can see from the upper picture where a triage nurse examines the patients, where you have four hypothetical patients who certainly have different diseases and need different treatments. So the patient is triaged to treatment A, B, C, D, depending on individual needs. And again, triage implies that resources are sufficient if distributed efficiently and correctly. Now we come to rationing. And I would argue that rationing is not part of standard medical practice. Under rationing, some legitimate medical needs will not be met. And rationing can involve a selection between two patients who will survive only with ventilator assistance, but who both compete for the only one available ventilator. Rationing exceeds medical decision-making. It's necessary to use medical knowledge to establish diagnosis, medical prognosis in the allocation decision, but under these conditions, there is a medical, moral, normative, there is sort of an ethical, not medical, moral normative component that is key for selecting who will be treated and who will not. And this is a completely different situation. And this is not just a medical decision. This is something that should probably be done by others than the individual treating doctors. So defining the pitfall, we would say that triaging and prioritization are a standard medical practice, are part of standard medical practice, and fall completely within the boundaries of medical expertise, while rationing is a normative practice that extends beyond medical decision. However, we see that these terms are used interchangeably, and by doing that, one creates a false sense that the allocation process is only a matter of medical professional expertise, while the normative content is hidden. Another pitfall, which is very close to this, is the misuse of futile care, because rationing is often based on alleged futility. Sorry about the misspelling there. Futility, not futility, is what I meant to write. And again, we may have hidden value judgments. People sometimes say that care would be futile because a resulting life is not worth living. This is a common argument, but this involves a paternalistic evaluation of value of life, which is not really asking the patient or even examining what is of value for the patient. Typically, what can happen is that a patient with a pre-existing handicap may be deprived of treatment during a pandemic because others are thinking that their value of life is not sufficient to require treatment. Another very common thing is the group level data use for predictive modeling. We all know that age is a risk factor, but the practice, which has been common in Sweden and in many other countries, I believe, to use the high group mortality for elder patients to depriving all patients of higher age of any care for COVID is, again, I would argue, a complete misuse of the term futile care. And in the same group of misuse of futility, there is also the relativization of the term futility. If two patients compete for one ventilator, they may have different prognosis. Let's say that one has maybe a 95% chance of survival and the other has a 40% chance of survival. Now, of course, I would argue that absolutely both have a reasonably high chance of benefit to motivate treatment. But under constrained resources, it is common that the concept of futility is used as a relative term, and people will compare and say that it's futile to treat the second patient with a 40% chance. Again, misuse of the term. I would argue that these pitfalls are bad. The pitfalls fuel a perception that providers make medical decisions by the book rather than value-laden decisions. And although these pitfalls may function as coping mechanisms to alleviate moral stress, it is bad for society and bad in trust for physicians' professionalism that we make hidden value judgments and that we are either forced or tempted to make these hidden value judgments to alleviate the moral stress. I would argue that we need to maintain professionalism and realize when we are dealing with ethical decisions. The ethical reasoning requires a distinction between ethical and medical facts. Physicians, such as us, are experts of medical facts. And as such, we must be professionally accountable. But we should avoid nebulous rationing strategies, and we should avoid making decisions that we cannot be fully accountable for. We'll just finalize with acknowledgement of the co-authors for two papers that this presentation is based on. Thank you very much.
Tit, thank you for this outstanding presentation. I am sure that all of us will find this meeting very useful, and I hope that the participants and who is looking the meeting on YouTube is also have a real benefit of this meeting. So I see the questions, Professor Basat Mistra, please, and then who will be the next? Just continue, Professor Basat Mistra.
Yeah, Tit, nice to see you, and very, very thought-provoking talk. While it is what you said is morally correct, the problem with many of us who work in environment which is slightly different from Europe, though in the pandemic time you were probably as badly hurt as us. We do have to take these decisions. I mean, whether good or bad, I don't know, but it's a part of our daily living, our daily practice. And this moral judgment, which is right. I mean, what you said is probably all right, but real life situations are different. You know, resource allocation is something which is new for you, is not new for us. You know, this is not new for many African countries, not new for many Asian countries. So doctors do take these decisions which we feel are for the good of the the people who we are treating. But very, very thought-provoking, and it makes question one's own judgment.
Thank you, Basant. I completely agree with you, and of course we have to make decisions. My point is that when we make a moral decision, which we are forced to do all the time, we should be aware that it may be a moral decision and not a medical decision. We should separate them. That's my point.
But how do you suggest? How do you go about it then? I mean, what is your answer? What is your solution to it?
Well, we have to make moral decisions, but we should be aware when we make the moral decision, when we make the normative decision. I mean, I haven't. Of course, there are situations in everybody's life, also before, outside, and after the pandemic, when we may end up in a situation where we are not able to treat all patients according to legitimate medical needs. But then we should first sort of look at the legitimate needs, see what we can meet, what we cannot, and then discuss the reasons for choosing who to treat or who not to treat. This needs to be transparent, and sometimes it should maybe not be the decision of the individual treating doctor. Maybe we need to have a committee. Maybe we need to have democratically elected politicians who decide on behalf of society how we should deal with issues such as choosing who will live and who will not. But my main point is that we probably make bad decisions when we are not aware that we are making moral, ethical, and normative decisions. I'm sure we can do this much better if we have conscious thinking about what we are doing.
Thank you, Tit. Thank you for this discussion. Next question is from Dr. Ken Darnotovich.
Dr. Mathiesen, thank you very much for very thoughtful, thought-provoking discussion. When I watch this, and of course, United States has been hit, as I showed on the graphs, as a negatively leading country in number of cases and deaths and what have you. I have not seen yet the situation where, thankfully, thank goodness, where we have to decide who will we put on respirator and who is 40% chance of surviving and who is 60% chance of surviving, and decide who lives and who doesn't live, just for full disclaimer. And also, thankfully, we as the neurosurgeons are probably not in that position or will ever be due to the fact that we have our pulmonary intensive care, critical care colleagues. At least in the United States, it's a completely separate specialty. My thought that you raised in this question, and I think we need to scientifically look into this. Some of the systems, even in most developed countries of Western Europe, sometimes, as I watch on the TV, are collapsing. And sometimes in some countries and during certain number of cases. And I think we need also to scientifically compare, not we as a neurosurgeons, but maybe medicine, as to, is it the socialist system? Is this the capitalist system of medicine? Is it the underdeveloped system? Which one collapses and when? What are the breaking points of the system where they collapse? That would be another thing. And then my second comment and question to you is, what are the medical legal challenges? As you all know, in the United States, they are enormous. If you decide who's going to die and who's not going to die, you're not going to lose your license to practice neurosurgery. You're going to lose your license to be a free man, and you're going to go to jail. Maybe in Europe it's different now. I don't know. I've been out of Europe for 30 years. but this decision cannot be made by physicians. This decision has to be made by lawyers and committees of the hospital and board of licensing boards of the state and country. So thank you very much for very provoking thought discussion. And can you make comment on these few issues, please?
Absolutely. I think you bring up a number of very relevant and important topics. I was, I must say, a little bit surprised, but in a very positive way, that you say that you do not see the problem of choosing who will live and who will die. Systems are very different, and typically in the European systems I've seen closely are the Danish system and the Swedish system. And Sweden isn't doing badly. I mean, they're among the best up there, with many people dying from COVID. It's a huge problem in Sweden, and we are right now. Scandal is unraveling where it becomes obvious that a lot of elderly patients in Sweden were just disqualified from curative treatment of COVID without seeing either a nurse or a doctor. They were just based on the fact that they were elderly. They were not considered for curative care, which I don't think you should put it in the framework of different political systems. What I do think is that if you start reducing values, it's let's say a political idea that all values can be reduced to a single comparative value. I think that's where you get problems, and typically both with a socialistic system and with a very capitalistic system, it's common to reduce all values to economical values. And I think that's the risk. What you should avoid is this reduction of values, and we must maintain among us as physicians a value of some kind of value of life, and consider this value to have priority when we discuss these topics. I think that's the best vaccination against misuse of medicine and rationing. So thank you very much. I think this is an important discussion, but I think maybe Marco should come in before we leave even the GMT time zone.
Okay. Thank you all of you for this excellent contribution. And I will now invite Professor Mario Fontanella with his topic, how to manage the neurosurgical elective case in a pandemic period. This is, I believe, one of the main concerns, and hopefully we might accept some recommendations. And Professor Fontanella is also proposed by Professor Karl Schaller to be a representative of European Association. He is as well also chairman of Web and Publishing Committee, WFNS. Marco, please.
Thank you, Lukas, for inviting me here. And I'm very glad to see you all well. I appreciate very much the topic and the speech of Tit Mathiesen. And I think that at the end of this pandemic, we all must to re-elaborate this period that is a very difficult period for all of us. I will speak about how to manage the neurosurgical elective cases in a pandemic period. In the first wave, in the first period of COVID in March 2020, Lombardy, the region where I live, which is a region of about 10 million of people, so inhabitants, was divided in 3 parts. One after Milan, parts of Milan, the bigger parts, the Brescia parts where I live, and the Varese parts. and all the elective surgery was stopped. So only urgent cases we performed. And now this is the second wave where you see that Lombardy region is still the more effective, about 400,000 cases, and but all Italy is affected now by this second wave. We have a lot of casualties, more than 54,000 casualties yesterday. These are the data of yesterday, and so is perhaps much more cases in all Italy, but in this second period we perform elective surgery. We have to keep this surgery because we cannot stop surgery. So we should have some to think how to perform surgery, how to perform safe surgery in this second wave period. Of course, as surgeons, we always think that the first thing is the patient. The patients come first, and the first thing is to keep the patient safe and to perform all the check to the patients to realize that the patient is protected. But we learn that I think here we are all chairmen, and for us it's very important to keep safe the staff. The staff protection is the first thing to manage elective cases, to perform elective surgery. And then we have to protect and sanitize the rooms, the hospital, and the third things is the patients. So we in the hospital between March and now, we perform a lot of lessons to all the staff, how to protect themselves, how to wear masks, how to change clothes, and not to share rooms, and to put the clothes in the same room, the people that works in COVID and the people that works in the not COVID wards. And we are keeping very safe rooms, and we are wearing very much to the staff. Every day, anyone in the staff coming by car or walking is checked with a fast medical check the entrance for temperature. Anyone nurse is checked early in the morning for the temperature, and in this way. So the first thing is to divide the COVID staff, the nurses, doctors, and the others that works in COVID wards, and the COVID-free staffs. They don't share things each other. For COVID-free staffs, they use FFP2 masks, and they undress themselves, and they use the dresses only for the hospital, and they change every day, and of course they sterilize very often the hands. And they are, it's very important because of course when we are talking about patients, we are performing meetings to wear mask, to keep the mask on, and to keep the wears on. Is very important, because we realize that the infections are between medical doctors, between nurses, between staff members. And every about 14 days, but whenever a staff member likes, we perform a COVID swab. Second thing is to protect the rooms, and we have, and this is the only one wards in my region, in Lombardy region, a special neuro-COVID department with 30 beds, where we have neurological patients and neurosurgical patients from all the Lombardy region, and is far away from the clean department, and is just for the positive patients. And these positive patients, they do perform surgery in the negative pressure OR, so we change our laminar air from, you see, from the ceiling, from negative, from positive to negative, and the clean stuff is performed, the surgery is performed for the clean surgery is performed in positive rooms. And then the patients, everything in elective surgery before surgery is performed outside the hospital. The nasal swab is performed about 48 hours, but outside the hospital, and also the CT scan. The CT SAST is performed outside the hospital. Patients are getting into the hospital when we are sure that they are COVID-free. And after hospitalization, before surgery, no relatives are allowed in the hospital. All the informations are, we do all the information, we send all the information through video calls. Usually we have one patient in one room, in some cases 2 patients in one room with a very long distance between one patient to the other, and all diagnostic and all the things must be in different, the pathways must be different from the COVID pathways. The OR, we have negative pressure OR as usual, and only surgeons and nurses directly involved are admitted. So no medical students or visitors are allowed to come in the surgical theater. No one is allowed to leave the room, the OR, before the end on the surgical procedures, and patients go directly from the OR, from the ward, because we have a very big awakening room where all the patients are put together after surgery, and we don't use anymore this awakening room, but the patients go directly to the ward. For different procedures, such as cellular or paracellular tumors, for transoral, transnasal procedures, we use this maximally safe protocol. The personnel in the operative room must wear a FFP2 covered by a surgical mask and face screen. We try to reduce the aerosol droplets generating maneuvers, and also high-speed drill is limited. And after surgery, patients cannot leave their room, their own room in the ward. The nasal swab is performed if, in any case, if temperature is more than 37.5 degrees. And the nasal swab is always performed before discharge or transfer to another department or hospital. With this procedures, we add from May to now 2 cases of positivization with the hospitalization. Two patients went positive during the positivization. These patients immediately were transferred to the neuro-COVID ward. All the other patients and the staff were checked. and all the patients were in quarantine and rechecked after 30 days, and the discharge was stopped. And the staff were put in alert mode status and rechecked for 2 times. Therefore, we have 2 periods. The first wave, the February-March, May period, we perform mainly urgent cases, about 400 surgical procedures. Of course, this year we do perform very few procedures, much less than other years. And in this February-May period, we had 12 patients positive, found positives in the ward, 2 neurosurgeons and 1 resident positive, and 6 nurses. And in the second period, 2 patients positive, but no doctors or nurses with this new procedure. And I think that we can improve this separating within the COVID-free ward, the elective urgent cases. I mean that even the urgent cases, when they are free, they are checked in the emergency room, and they are checked for COVID for several hours. They come in the ward, but they are not so strictly separated with the other patients. And I think we will need a strict separation between the emergent cases and the other cases. But I think that with this new protocol, I think we can succeed in this bad war. Thank you.
Thank you, Marco, for this excellent presentation. So paper is open for discussion.
May I ask something to Marco?
Yes, please.
No, I would like to, first of all, I would like to congratulate for the organization of the neurosurgical departments in your region with the different tasks, and this is a good way to manage this difficult time. But my question is, in this second wave, for elective cases, did you need to postpone a percentage of elective cases for surgery?
Well, we did perform very few cases in this second, in comparison with 2019, because of course we think that all these exams before the admittance takes a very long time, and some cases are postponed because we have very few reanimation beds in the intensive care unit. Of course, if I have a frontal right meningioma that can wait for months for surgery, I'm not going to perform surgery now. Because we have very few beds in the ICU. I think that in the first wave, we had very few trauma patients because all was locked down. Now our ICU are fully booked, are full of COVID patients, but also with urgent cases. So if I have to perform a tumor, I don't know, a tumor that needs ICU is very difficult. So yes, we postpone a lot of cases.
Thank you. This is.
I don't know. I was really thinking about the different way to face this COVID period in the different location in the world. we used to say that Lombardy is a very good medical organization in Italy, but we had the most of the cases of COVID. So something wrong, there was something wrong, I think. And I think in other countries, COVID patients were very few. So perhaps other countries were much better than us. I don't know if we are so good. I really wonder if with all this stuff, all this thinking, we are so good. I'm not sure. I'm not sure because we have a lot of casualties, also a lot of casualties, not only a lot of cases, but a lot of casualties. So our system, I'm not sure that is so good.
Thank you, Marco. Thank you for this excellent discussion. It is my pleasure now to invite Dr. Andreas Demetriadis, President-elect of European Association of Neurosurgical Societies, who is all the time present with us, following the meeting from the very beginning. Now, I think it's the right time to say a few words for us and to address us on behalf of European Association and his personal name. Thank you, Andreas, for being here with us.
Thank you, Lukas. Thank you, everyone. In brief, my congratulations to you and the Serbian Neurosurgical Society. We had excellent presentations from across Europe, Asia, Africa, America, and the world. There's plenty of material there for reflection as we're passing through the second wave of the same pandemic in 2020. So while I've been quietly listening, all I can say is well done again for organizing this. Personal greetings to everyone and warm wishes from Edinburgh for hopefully a better year ahead. Thank you.
Thank you, Andreas, and please stay with us until the end of the meeting. I hope it will be in the next half an hour. So thank you all of us for the patience and to being present all the time during the meeting. It means really to me, and I think it means that we achieve a real success together in making this meeting so interesting that we are all here, and you will hear in the end the numbers of the participants and attendees and everything in my closing remarks. So now back to the Southeast Europe, from northwest to southeast, from Slovenia, Professor Roman Bošnjak and Tomaž Velar, management of neurosurgical patients during COVID-19 pandemic, Ljubljana experience. And then we go south to Macedonia and Montenegro, and then we will finish. Thank you very much. Tomaž, turn on your microphone, please, and continue.
Good afternoon. Can you hear me now?
Yes, we can hear you, yes.
Good afternoon. Thank you very much for your kind invitation and the greetings from University Medical Center, Ljubljana. Today, we would like to present you the Ljubljana experience in management of neurosurgical patients with COVID-19 during the pandemics. The novel coronavirus disease is an emerging disease, and because of this virus, a new public health crisis arose. Despite the maximal worldwide public health responses aimed to contain the disease and delaying its spread, many countries have been confronted with a critical care crisis, and even more countries will almost certainly follow. In Slovenia, the COVID has struck the health system immensely, and among all the specialties, the neurosurgery has also experiencing difficulties in service, not only in regular services, but also in elective surgeries, and especially during the emergencies. The management of these patients has become very difficult now in these days. And most neurosurgical emergencies require a prompt consultation for the intervention in order to achieve the optimal outcome. So that means that the fluency and the speed of treatment is of vital importance. The first factor here is the promptness of transportation. And the time to neurosurgery and the distance of transport to neurosurgical center in Ljubljana significantly affects morbidity and outcome of the treatment. It is well known that approximately 10% of patients with a mean transfer time of over 4 hours may encounter a drop of Glasgow Coma Scale during the transport. Those who experience delay of more than 4 hours before surgery have a higher mortality rate compared to those that come to neurosurgery service directly. And the distance to neurosurgical center is therefore one of the main factors that causes delays in treatment. The usual transit time at our center varies. It's according to the type of transport, depending on the helicopter or road transport, from 1 hour to 4 hours respectively. And the second problem now is the COVID infection that delays the management. All emergency patients in Ljubljana, when they are admitted, they undergo virus testing initially, and even in the best occasion, the rapid antigenic test needs about half an hour to be completed, therefore prolonging the neurosurgical treatment. This fast antigenic test has been used from October at our center and offers rapid testing. The PCR test, on the other hand, has higher sensitivity, but needs even longer to be completed, and in emergency cases it cannot be used. Therefore, we use this test only for elective patients, and then later on during treatment also for emergency patients, but once they are already on the ward and once they have been operated on. Additionally, the emergency patients are handled according to special anesthesiological and surgical procedures. The personal protection equipment is worn at all times, including special gloves, as you all do, gowns, eye protection, face masks, and eye shields, and the flow of staff into and from the operation room is minimized. Special care here is taken for the equipment and also post-operatively. All of these challenges may compromise the patient care and treatment outcome, but the healthcare system also incurs significant costs. But unfortunately, we do not have any other possibility to manage this patient. We have to stick to these rules and these procedures. This is a simplified Ljubljana protocol to be presented for this meeting. At the University Medical Center Ljubljana, the neurosurgical patients who present to department are all screened and evaluated. Screening is done for potential risk of contracted COVID with the rapid antigenic test, as I have said, in the emergency cases, and the PCR is done in the non-urgent patients and in the elective cases. They are accommodated, these patients are accommodated in so-called gray areas. These are temporary areas that can be used until these tests are positive, are negative. This is a picture showing our gray area. Once the patient comes in, he's here, he waits for the tests, and once the test is negative, he can be moved to the ward. But this is only for the patients that can wait. From other hospitals, the transfers are also important. The patients are transferred after the test results are available in order to avoid the potential spread of virus to the main clinic, and emergency patients undergo this protocol, and all admitted patients are also categorized on the basis of emergency intervention. Those patients with life-threatening emergencies are operated on immediately. The inclusion criteria for this emergency surgery includes the following: all pediatric patients and adult patients with raised ICP due to various reasons, all traumatic cases that need emergency operation or observation, and of course spinal and compressive myelopathies, and also vascular emergencies of various kinds. And these urgent cases are triaged according to the complexity of the case, the availability of surgical instruments, of course also the availability of the anesthesiological team, which is a real problem now, and also the ability and availability of post-operative accommodation. This is COVID and versus non-COVID emergency rooms. We have separated this for various patients. The urgent cases that could be handled with the current setup are operated on according to a semi-emergency list. The patients with no exposure to COVID, these are the elective patients, and those without the acute respiratory signs and symptoms with a normal chest radiograph are considered low risk. And these patients also are tested with the PCR and also with the questionnaire that have to fill in. And this is done basically in every patient that comes to the ward. Also, special precautions are taken. Personal protection equipment is worn at all times by all staff that works with the patients that are treated on the ward. The low-risk patients are operated on by one neurosurgeon and assistant, always with the N95 mask or FFP3 mask, and also face shield in addition to standard surgical gown and attire. And all the staff, the anesthesiologists and the support staff, use the same precautions. In case of high-risk patients, on the other hand, and those that have confirmed COVID, and also the unknown cases, the special precautions as described are also taken. This is shield for the face that is used on the ward and with the staff that is involved with the work of patient. And on the right picture, you can see a specially equipped operation room with the, as we have heard today, with the negative pressure inside that is especially designed and was adapted from the operation room, from a standard operation room for the COVID patients. The mobility is also limited when we are dealing with a patient with COVID. The mobility in and from the operation room is restricted to one entrance and one exit. The floor is also disinfected with alcohol and with chlorhexidine solution, and this solution is kept there in order to limit the potential spread of the virus on the footwear. And the auxiliary staff that is working with this within the operation rooms and in the outer area also wears shield masks on top of their three-ply surgical mask. In the ICU and on the ward, the same precautions are taken. Special areas of the ICU for COVID patients have also been established, and these patients then go directly to these emergency rooms. These are photos showing the, you can probably see it here. One gentleman that is working as auxiliary staff in our operation room has a surgical mask and also protective shields in addition with the gown and attire that is needed for working with these patients. And these are specially equipped operation rooms with for patients with COVID. You can see all surgical staff wears special equipment, and also the staff, the number of people that is working inside the operation room is limited to minimum. The PCR is additionally done according to the needs during the recovery period once the patient has been transferred to the ward, and additionally these patients are also discharged home as soon as possible post-operatively once they are okay, in order to generate the capacity to cope with more cases. Thanks to the neurosurgical consultations we have via the telestroke system. This is a kind of telemedical network we are using in Slovenia. For the consultations from distant hospitals, the velocity of action is higher, and also the possible unnecessary transportations are limited, thus reducing the risk of infection. Besides, the medical personnel is tested every 2 weeks with a PCR test, and those that are positive are sent home temporarily. And we have, because of that, a lot of problems with the recruitment of personnel. Some of our nurses have been transferred to infection wards, and others have to be in isolation. So we do not have at the moment plenty of this personnel that can be used for a COVID patient, but still we can manage the flow of patients normally. This is a schematic representation of the flow of patients that come to our department. Here you can see neurosurgical patients, neurological patients, and neurotrauma patients. They all come to the surgical emergency department, and once they come, the PCR is done. Those who can wait, those who cannot wait, those have the priority, and according to the COVID tests, they are transferred to red zones, so-called areas for infected patients, and then once they are okay, go to the central ICU. If they are not okay, they go to the special area, also ICU area, which has been especially adapted for these patients. The other leg or the other arm of the this flow diagram is okay. These are non-infected patients which are not dangerous, and also here we have a special separate arm for elective patients, which goes directly to gray zone, as I have discussed before, and then they are managed accordingly. If they are positive, if we find that the tests are positive, they are sent home. Also at the outpatient clinic, we have special regimen. The patients have to fill the questionnaire. They also have slots for consultations. We use the separation in sitting in the waiting room. We use frequent ventilations before the patient comes and after the patient goes. We always ventilate the rooms. In order to keep the fresh air. We also use the face shields and mask, and we take the great advantage of the e-consultations and telephone consultations, and especially important is the COVID helpline that is in use. And with these restrictions, I really hope that we will try to limit these pandemics and also to keep pace with the inflow of patients that is coming to our center. Thank you very much for now, and I would like to hand my word to Mr. Professor Bośniak, who is the chair of our department, also to say a few words. Thank you.
Please, Roman.
Yeah, maybe I would like that, Tomasz, that can you stop sharing, please?
Just a moment, yeah.
So, just... Dr. Wellner is one of our survivors. So he was at home in quarantine and he survived coronavirus infection too. So I would just like to add a few practical points. So as you see, as a small country, we were the first in the Europe who declared end of epidemic, the first wave. However, we could not stay in a bubble because the cross-border traffic was not closed, especially around summer months when there were holidays. And we believe that this input of infection disease, this produced the second wave. So now you can see that at the moment, we, as our facility is for about 2,200 beds, and there are about 1,300 doctors here. So we've organized the same way as in the first wave. So we immediately separate COVID plus and all the others, but this time the epidemiologic anamnesis was not the prime selection criteria, but we put the PCR tests as the first measure. So everyone who comes to department has a test and he can wait in the gray zone, but our department is challenged by emergency cases that are coming from the region and from other peripheral hospitals. And as you see in the table is before, then all who can wait, they were waiting for PCR. Now from the late October, we are doing the antigen test. So this is not a problem, who can wait, who cannot, but the others have to be operated in a personal protection equipment. So here is the current state in Slovenia. So we are having about each day 22 to 25% of positive. So these are the data of the Friday. And the test is about nearly 7,000 and 1,500 cases were positive. This is 22%. So yesterday, during the weekend, the tested number is less, but the positive is higher. This is always. So we think we now approach somehow to the plateau. And we have about 1,600 each day. It's now for several days ago. And we have a lockdown, so no schools, no restaurants, shops, hairdressers. And we have also the police hour, as we said, from 9 to 6. So the problem which come to our department, this organization in our hospital was shown here. So we do not have our own intensive care unit, but this is a central unit. We have only intensive nursing for 24/7 days control. So the problem come out for the patients who don't need ventilation, who are for the intensive nursing, and if they were in a contact. So if it comes, there is a contact, they should be taken care and on special area inside our department. So, but we do not have a staff. So one of the measures was redistribution of the staff. So our department gave about 20% of nurses who were highly educated for intensive therapy and intensive nursing. And now for our own intensive nursing patient, which is kind of recovery for patients after surgery who don't need ventilation, but our call is from surgical clinics, from other departments. They want that every department takes care of such cases. So we do not have staff for this, and this is now a micro problem of our department. So we are looking that we would get our personnel back. So this is some kind of pictures and public reality. Also there in Slovenia, there were protesters who did not accept our efforts to be for true. So I would finish with this, and please.
Thank you, Roman. Thank you, Tomasz. I suggest that we move on the next presenter, Dr. Alexander Chaparovsky, Professor Alexander Chaparovsky from Macedonia, who will tell us organization and treatment of neurosurgical patients in time of COVID pandemics in North Macedonia. Dr. Chaparovsky used to be a president of North Macedonian Neurosurgical Society. As well, he is a member of the Southeast European Neurosurgical Society Executive Committee.
Lukas?
Yes, please.
Good afternoon. Can you hear me?
Yes, we can hear you and see you. Just play your presentation, please.
Okay. Good afternoon to everyone. Dear colleagues, dear friends, I'm very happy to see you again, healthy and all in good condition. I hope your family are also doing well. Thank you very much to Serbian Neurosurgical Society and to you, Lukas, for this invitation. It's a big pleasure for me to be part of this virtual Congress and to share our experience in dealing with COVID-19 infection in our country. First of all, I would like to give some general information about our country in North Macedonia. We know we are a small country in the middle of the Balkans, Southeastern Europe.
Start your presentation, please.
Sorry?
Start your presentation.
Yes. Can you see on the screen? I already start.
We are seeing only your desktop. I mean,
sorry. Just a moment.
Play on the.
Yeah, I will try.
Play on the.
Just a moment. Now, do you see now?
Yes, now it's okay.
I will give you some general information about neurosurgery in North Macedonia. We are a small country in the middle of the Balkans, Southeastern Europe, with population with 2 million people population. Our capital city is Skopje with about 800,000 citizens. Our neurosurgery university clinic is unique. It's only neurosurgery residency training center hospital. Our clinic was established in 1988, and we became independent from the general surgery in 2007. After the independence, we have opportunity for faster development using advancement in new technology and equipment. Now, in our clinic work 10 specialist neurosurgeons, 2 residents. We have a ward with 245 beds and intensive care units with 11 beds. As you see, we are able to use almost all kinds of modern equipment in our everyday activities. We have 2 operating theaters every day, but during this pandemic crisis, practically we have to work only in 1 operating theater because our anesthesiologists, mostly because our anesthesiologists were undertaken and they have to work in the COVID center for to help the COVID center in the patient in the COVID center, and also from the government. Many times we have suspensions of the elective program, and we practically mostly we use only 1 operating theater during this pandemic crisis. We perform about 1,000 surgeries per year. Many patients were successfully treated in our country with good outcomes. And we performed almost all kinds of complex surgical interventions, including in pediatric neurosurgery. Now about COVID-19 pandemic in our country. The first case was registered in the beginning of the March 2012, and he was imported from Italy. There are 2 peaks so far, as we know. The first was in June, and the second peak in our country started in the beginning of October. And I already say I'm very happy till now because there are some good signs that we are on the peak, on the top of this second wave. And finally, the number of the patients started to decline. And it's also most important, the pressure of the health system and the hospitals started to relieve for the patients who need hospitalization, mostly the patients who are in bad conditions and who need to be hospitalized in the intensive care units. Till now, our country conducted almost 300 to 25,000 PCR tests. 60,000 were positive. Now we have almost 1,070 deaths. Its mortality rate is 2.7. And also still the number of active cases is still very high, 21,000 patients. Now organization of healthcare system during pandemic crisis in our country. The organization of the healthcare system was structured in a manner that all the patients diagnosed with COVID-19 who needed surgical care, including neurosurgical treatment, were admitted in a different and isolated hospital. Our colleagues from ex-Yugoslav Republic maybe know that hospital. It was ex-military hospital. It's a very big hospital with 400 beds, and it was main COVID center in our country. Our university campus was planned for the treatment only for urgent cases who were not tested for COVID-19 yet, and for the elective cases with negative COVID-19 testing. That was very good system who works very nice because all the patients who were tested positive, as soon as possible, we transfer them in the COVID center, as I mentioned. But during the exponential growing the positive patients, increasing number of patients who are positive, we have to change our policy. And after this exponential increase of COVID-19 patients in October, beginning, it was about 1,200 cases per day continuously, and overloaded all the COVID centers and all the other hospitals. We also had to reorganize our clinic and adapt our admission treatment of COVID-19. Time was very difficult to find a free space or free bed to hospitalize some COVID patients. We have to adapt a small intensive care unit at our clinic with 4 respiratory machines and 2 rooms with the 6 beds in an isolated part of our department for patients who were admitted as urgent cases and with pending COVID-19 results. We adapted also 3 additional rooms designed for safety, preparation, and decontamination of the medical staff, treating the suspect cases in accordance with the WHO recommendations. 1 operating room was planned for surgical treatment of suspected or diagnosed cases of COVID-19. From the beginning of the COVID-19 pandemic of our neurosurgical department, we registered a total 41 cases with SARS-CoV-2 infection. It's about 5% of all admissions in our department. The majority of these patients were admitted as urgent cases, traumatic brain injury, hemorrhage, tumor, and spine pathology. 50 of those patients required urgent neurosurgical treatment. We had 7 dead, and 3 of them were related with acute pulmonary distress syndrome. The case of mortis or death was directly related to the COVID-19 infection. 60 employees were infected in our department, including me. I can say I was lucky because I was practically asymptomatic. It was 2 months ago. I can say I was like Professor Kenan Anutovic says, I was very careful. I was always with my N95 mask on me. Sometimes I have some double protection. I put another mask on me, surgical mask, but I get infection. I really don't know where. I try to understand, but I never know how get this infection. But I was happy because of that all my closest collaborations and my assistants who work with me hours and hours at work, and we are in very close contact, none of them get infected. How can I say, I protect them from me, from myself. On the end, I want to say the COVID-19 pandemic is a new reality, and we have to constantly adapt and reorganize in order to give maximum quality of treatment to our patients. In comparison with 2019, our department has less effective cases, almost 200 approximately. In 2019, we have 1,033 surgical procedure. Now, as I planned, we will finish with 850 approximately this year. It's less operation, but we don't note any statistical variation in the total amount of admissions compared with 2019. Now, on the end, I want to remind you that last international meeting in our country was WFNS course 2017, who was organized in Ohrid successfully. I hope after finish this pandemic, I will warmly invite you, all of you, to be our guests to visit our country. There are many reasons to come. You will never regret, and I hope it will be. We can see each other very soon.
Thank you, Dr. Chaparovsky, for this presentation. Of course, we are all very eager to come in North Macedonia again, and we know that you are very famous for your hospitality and for your readiness to organize things. Now I will suggest to move on for the next speaker, but first of all, you have to stop sharing your screen. I think your internet is a little bit problematic, so you have to just stop sharing your screen. Now it's okay. 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 Perfect. And I would like to invite our colleague, Dr. Slavko Đerašković, also a member of the Executive Committee of Southeast European Neurosurgical Society, Vice Director of Clinic for Neurosurgery in the Clinical Center of Montenegro, to tell us about the impact of COVID-19 on neurosurgical practice in Montenegro. Please, Slavko.
Greetings from Montenegro to all of you. I hope you can hear me well.
Yes, yes, we can hear you.
Lukas, thank you very much for inviting me for this great event. Just to share my my presentation. Yes, you can see my presentation, I hope so. Well, I will talk about neurosurgical practice in a clinical center of Montenegro during COVID-19 pandemic. This is numbers, COVID-19 numbers for Montenegro. Our population is about 650,000 people. And from the beginning of the pandemic, we had more than 33,000 coronavirus cases. We also had more than 21,000 recovered patients. And at the moment, we have more than 11,000 active coronavirus cases. And we had more than 460 deaths from the beginning of the pandemic. In Montenegro, we have two neurosurgical departments. Main department is Clinic for Neurosurgery in Clinical Center of Montenegro, which is a scientific and research center, and also educational center for our residents and medical students. And our department have 5 neurosurgeons and 5 residents of neurosurgery. And in Montenegro, we have one small department in special hospital in Risen, which have 2 neurosurgeons and 1 resident of neurosurgery. Due to the decision of the crisis medical team, Clinical Center of Montenegro became a COVID hospital, and the special hospital in Risen became Clean Hospital for Orthopedics and Neurosurgery. On this slide, you can see organization of the neurosurgical practice in Montenegro. Special hospital in Risen became a Clean Hospital, so every elective neurosurgical cases who can't wait were transferred to special hospital in Risen. Also, some second level emergencies were transferred to Risen. Clinical Center of Montenegro became COVID hospital, and we treated all emergency neurosurgical cases, also vascular cases and pediatric cases who can be treated in a special hospital in Risen were transferred to a clinical center of Montenegro, especially ruptured aneurysms, AVMs, subarachnoid hemorrhage, and so. Every COVID-19 positive patient from the special hospital in Risen were also transferred to clinical center of Montenegro. This is the treatment of emergency patient in clinical center of Montenegro. We tested every patient on admission. We used only PCR test from the beginning of the pandemic. And until we got PCR, every patient had been isolated in separated rooms and treated as coronavirus positive. At the beginning of pandemic, we had problems with testing. We must wait results for several days, but now we are better and we have results in 1 day. During every emergency surgeries, we regularly use the protective gears, N95 mask, goggles, and water-resistant overalls. Also, in emergency unit, we use the mask, gloves, goggles, and face shields. In our department, we formed a 2 doctors team on neurosurgery who rotated every 15 days to lower the incidence of coronavirus infection among staff. Nurses teams rotated every 24 hours. In the outpatient service, we accept patients regularly when the pandemic is under control, but when pandemic worsens, we treat only emergency cases. And at the moment, we also treat only emergency cases at our department. Coronavirus cases in our department, I can say among surgically treated patients with coronavirus, 70% patients recovered and were discharged, but 30% surgically treated patients with coronavirus unfortunately died, and it was usually due to pulmonary complications. One patient from our infected at our department and unfortunately died due to lung problems. And at the moment at our department we have 2 patients with coronavirus. That is a patient with subarachnoid hemorrhage, non-aneurysmal, and a patient treated for epidural and subdural hematoma, and they are in good condition. We had infections at our department. 2 doctors have been infected. One of our residents infected with coronavirus, but he recovered and went back to work. And also me personally infected with coronavirus 2 weeks ago. I had mild pneumonia, but I recovered and I'm in good condition now fortunately. I can't for sure say where I infected. Last month we had a lot of cases at our hospital, and it increases every day. I had also a lot of contacts either in emergency unit, and on our department we have some COVID rooms, and the patient we visited every day. So I can't say for sure where I infected for coronavirus. virus, but one advice for everyone who have coronavirus infection, even mild symptoms, I suggest to perform CAT scan of the lungs, because we have in our hospital a lot of cases with even very mild symptoms who have pneumonia on CAT scan that can be seen on X-rays. That is my case also. We have nurses infected with coronavirus too. 4 of them recovered and went back to work, and one nurse is currently infected, but she is in good condition. And also one colleague, a neurosurgeon from a special hospital in Riesen, infected with coronavirus, but he recovered and went back to work. At the end, I will emphasize our main problems in our hospital. Large numbers of elective cases were postponed, especially degenerative spinal cases and treatment of unruptured aneurysms and controlled DCAs. We have problem with resident training because we lower our surgical job for approximately 60% compared to the last year, and also problem with medical students training, and at the moment we do it online. Thank you for all of us for patient listening.
Thank you, Slavko, for this presentation, and just stop sharing your screen. Now it's my particular pleasure. For the end, I would like to thank you for just ask for a few minutes of patient, our dear colleague and friend, Professor Claudio Polski from Argentina, from Buenos Aires, had an emergency case this morning, and he was supposed to speak this morning. He will just now want to join us and to say hello, which makes us 100% of lecturers attended this meeting. And thank you very much, Claudio, for your having strength to join us after this situation, what you had in your department. Please.
Good morning, dear Lukas. I really apologize yourself and everybody, because you know it's our work, and I'm on the cell phone now, so I cannot share screen. But just if you wish to tell you a few words on the situation on Latin America, just to summarize, just very briefly, of course, because it's late, I know. Of course, we have in Latin America, we haven't been the exception of this pandemic, of course, later than in Europe and Asia, but we began in our different countries with preparing and different protocols to deal with the pandemic. And just to tell you that we made a few months ago a survey among 21 different countries in Latin America to see what the impact of the COVID pandemic did. And we reported initially in the first months 80% of reduction of consultation and surgery performance, and it had a very strong impact on the reimbursement of the neurosurgeries. Most of the neurosurgeons in Latin America, mainly the young neurosurgeons, they claim for a problem with their incomes. There was an economic restrictions, and that, of course, poses a significant risk for unsustainability. So now we are a little bit better. We are waiting for the second wave, and hopefully the vaccine will come earlier. But we are around 50% of our elective procedures done in most of Latin American countries. So things are getting a little bit better. But nevertheless, I think there are new opportunities with this pandemic. Mainly what happened, what is happening with neurosurgical education, that we have now many webinars, and this new tool that it has come to I think it will be continue after the pandemic. And well, we think that in the near future we will have to begin again with our regular work in this new condition of pandemic. That I'm running a big department. It's 1,000 beds, and now we had in the worst time of the pandemic 300 COVID patients, and now we only have 30. And so we are beginning, to work a little bit better. So I think that we have to keep on working and dealing with this pandemic, since all the people will be vaccinated and immune, that it will take perhaps a long time. So just a few words. I don't want to keep on working. So thank you, Lukas. Thank you, everybody. Lukas?
Lukas, we can't hear you. We can't hear you. Okay.
Sorry. At the end of this very exciting day and long-lasting Sunday, let's say morning, afternoon, depending where we are now, are in which part of the world, or evening, I would like to thank you for your outstanding contribution to make this meeting extremely successful. I believe that we all share an experience that this meeting is very useful, has been very useful to all of us, and has been very useful, I believe, to all participants who are now watching, or have been watching, or will be watching on YouTube this meeting. And some of the ideas, I exchanged some messages with Franco Selvadei about the idea to present this meeting as a conjunction meeting with WFNS as well with ENS, if Andreas is agreeing. And then because most representative and most distinguished neurosurgeons from all over the world, Europe, Southeast Europe, are give us a privilege to learn from the experience in fighting with this COVID situation, which is very useful for all of us. At the end, I would like to say that there is a very similar situation in Serbia. So far, in all neurosurgical centers in Serbia, there are all of them experienced transformation in as either a whole department, either part of the department as to be a COVID center, except our clinic. Our clinic for Neurosurgical Clinical Center of Serbia, still did not operate any one COVID positive patient. COVID positive patients are operating, neurosurgical patients are operating in our department in the emergency center. So we keep all elective cases as much as it is possible to be operated here. But generally speaking, problem is that at the beginning, very few of our employees have been in contact with COVID virus or have COVID infection. One neurosurgeon and one nurse at the spring, and in the second part in the autumn, let's say, maybe few of them. Now we have several neurosurgeons and several nurses positive, but they are not working now. Of course, they are in a hospital or in isolation. But still, if we let's say find some patient positive at some moment at the beginning, we are doing PCR tests, serology, fast antigen test several times during the hospitalization. But still we have some patients which we find positive during the hospitalization in our clinic. At that moment, we move the patient to the COVID departments, which are completely COVID departments or neurosurgery. So far, we are not. We were able, despite this third wave, which was still is quite difficult in Serbia, to avoid transformation of clinical for neurosurgery to a COVID hospital. This is due to the situation that our clinic is surrounded by 25 other hospitals within the large giant clinical center of Serbia, and then all of these hospitals are already transformed or very quickly transformed into COVID hospitals. So this is on that situation. On the other hand, problem are employees, I mean nurses, anesthesiologists, anesthetists, and all other employees as well. Now we have several neurosurgeons with COVID contact, but we diminish completely the program, including elective cases. But so far, we are trying to find the best possible way and solution for doing this. Just a few minutes of your patience to share some slides with you regarding this meeting, which is now ongoing. So for the first time, we were in the situation to organize a virtual exceptional meeting. We called it exceptional because we believe strongly that this meeting will be the last one that we are organizing virtually on this as an annual meeting of Serbian Neurosurgical Society. We will see. This is a sixth annual meeting of Serbian Neurosurgical Society with international participation accordingly, and this has achieved a great success thanks to you and thanks to your patient for this 6 hours event during this Sunday meeting. So we would like to thank international surgical community for friendship and support, international experts to be part of our activities. COVID-19 and neurosurgery will still remain a huge problem in future, and we will see how it will find a solution for this. Some of the initiative might appear, if you agree, that in relation with this kind of world, Europe, Southeast Europe, and Serbia connection, now we can create some our let's say remarks. We put in one mutual scientific paper to be published. This is just for your considerations. We have a 2 days meeting, 24 presentations, 222 registered participants, 54 countries, and 406 viewers on YouTube participants so far. We will send the official report to the WFNS and DNS within next few days with total number of participants at that moment. And this year we are celebrating 82 years of the Clinic of Neurosurgery Clinical Center of Serbia, 97 years since the foundation of neurosurgery in Serbia. This meeting should happen this year at this day, very same day, but we postponed him for the next year. So this is a current concept of military neurosurgery state in the field. All of you received the invitation, and of course our major event, which is ENS Congress, which should take place in Belgrade in October 18 to 22nd this year, was not able to organize in live. It was exceptional virtual meeting of ENS at that days, but we postponed and we rescheduled the Congress in October 2022. So it's 16 to 20 October in 2022, and accordingly invite all of you to come to Belgrade as soon as possible, as well as I will come to your place as soon as this situation has been relaxed, because my passport is a little bit frustrated. It didn't receive any stamp from the border from long time ago, and I cannot handle this situation because he's getting a little bit nervous. So thank you very much once again. If any other would like to take final comment or remark, I would really appreciate.
Lukas, I believe that this meeting was really well organized as usual, and we enjoyed too much, because to share different experiences and different thoughts is very important for the neurosurgical community. You have the great merit to join. You join. And we are very delighted to be joined, just to see all friends through the screen, not in person, but I am sure that we will meet each other very soon. I have only a bad information a few minutes ago, that French people, 60% of French population don't want the vaccine against coronavirus. And probably there is a similar situation in Italy, and it is at this time so bad, but I hope that they will change their mind in the near future. Thank you so much, Lukas, for this great opportunity.
Thank you very much, everybody. There are several quite positive comments on the panel. I would not read it now. I will send you via report, which you will receive, all of you, regarding the meeting, like usual. Now we are almost all here to make a mutual screenshot. If Ibrahim, if you are here, please turn on your camera to make a mutual screenshot photo now. Ibrahim is not hearing, maybe, but might be here. Okay. Anyhow, we'll make a photo now. So we tried to take several photos during the previous period, but always some camera was turned off. Anyhow, thank you once again for this wonderful experience and wonderful learning opportunity for all of us. If anybody would like to take some farewell remarks or comments, please do it. If not, we can say goodbye with one for the road. This is, by the way, tea, but I will take now one whiskey, of course, Jack Daniels, you know it. So one for the road, for very soon meeting each other. Cheers.
Thank you, Luki.
Thank you. So now host will end the meeting.
Okay. Cheers.
Bye-bye. Thank you.
Thank you, Lukas.
Thank you.
Thank you so much. Bye.